We are starting the session on STEMI challenges and choices. I invite chair to chair the session Dr. Rajesh, Dr. Rakesh, Dr. Shwanan, and the panel of experts are Dr. Binoy, Dr. Paswa Kumar, and Dr. Kumar. The first talk was on STEMI intervention in post-CABG challenges. Over to my all chairpersons.
Good evening, all. Am I audible? I think I am. I think this is going to be a very interesting session, and I would not waste much of time. I think let's start with Dr. Anil Dhal. Anil, you ready?
Yeah, sure.
Yeah, sure. I think we won't waste much of time. Dr. Yadav is also over here.
Yes, I'm here. I'm very well here. I think we should start session.
Yes, absolutely.
And we will have a discussion later on.
Yes, yes. Anil, over to you.
Can you see my slides?
Yes, yes.
Yes. Dr. Anil, welcome. Yes.
Oh, thank you, Rakesh. Thank you, Rajesh. It's good to be with friends. And starting this very unusual CSI, a hybrid CSI, full credit to Dr. Monan and his team for having organized this wonderfully. So my task is very simple because he's worded the topic as challenges, and very clearly we all know that the long-term outcomes of bypass surgery are influenced by two major things. One is the progression of atherosclerosis in the native coronaries, and also the degenerative or atherosclerotic changes in the graft. And these patients, as we all know, since we at first decided to send them for CABG, they are a high-risk group, and therefore they are going to be worse clinical outcomes. And this is clearly an independent risk factor for adverse clinical outcomes in patients presenting with STEMI. Needless to say, it's a very heterogeneous group. It's a high-risk group, and treatment needs to be individualized because there is going to be a higher incidence of adverse outcomes, and you have to actually individualize clinical judgment. So even if we just take angina after CABG, it can happen because of native disease progression or a bypass graft failure, which can be either arterial or venous. And in arterial, we also know that sometimes the route to the lima may actually be the left subclavian, and we have to keep that in mind. And the high risk, because these patients are generally older, they have a plethora of more cardiovascular risk factors, comorbidities, they have worse LV function. Angiographic findings also suggest more extensive disease, higher TIMI risk score, severe culprit stenosis, more fibrous, more calcific, more CTOs, and are therefore more likely to be refractory to normal medical treatment. A large number of them are going to have LV dysfunction and heart failure. And we also know that the choice of conducting a reduced CABG is kind of difficult. And STEMI patients who come post CABG are less likely to receive early invasive reperfusion. We have lessons from several STEMI registries, all of which confirm just about the same, that a large number of these patients often remain undertreated or untreated. There could be some diagnostic challenges because they could have pre-existing abnormal ECGs, as well as some of them may have atypical clinical presentations. But when we combine biomarkers and we combine some echo analysis, especially if you've had a longitudinal follow-up of the case, you may be able to have an early diagnosis. Definitely, these patients have a higher mortality. It can be a big challenge to identify the culprit vessel because there is a variable collateral supply which can come through the grafts or the native. The culprit could be the native which has not been revascularized, because surgeons, as we all know, don't always follow the suggestions made by the referring cardiologist. There could be a new lesion. There could be a progressed non-critical disease which in the index angiogram was non-critical. It could actually be a problem in the graft itself. Of course, the choice of conduit being arterial or venous is something which we know the challenges when we offer these therapies, and we know that vein grafts do offer some advantages, that they're accessible, they have adequate length, diameter to facilitate the stenosis. But over a period of time, there is a definite pattern of vein graft attrition. We know that 20% of vein grafts, 15 to 20% decline in the first 6 months to 1 year. And thereafter, it's 1 to 2% per year for the first 5 years and 2 to 4% per year between 6 to 10 years. And this is by the time it's 10 years post CABG, we already have 50% graft attrition. And this could be initially could be technical reasons, then we could have some internal hyperplasia, then atherosclerosis and thrombus, and subsequently. So if you look at the time course, people have actually looked at them very carefully. Early vein graft failures because of endothelial injury. Thereafter, and some technical reasons, after the first month, it could be exposure of the vein graft to arterial pressure and neointimal hyperplasia. And this non-occlusive thrombus gets progressively organized with accelerated aggressive atherosclerosis even in the native vessel. And this in the vein graft leads to the formation of a gruel, which is quite unlike the thrombosis that we have in the native vessels. The atheroma is often diffuse. I'm calling it atheroma for want of a better word to use. I could have used gruel. Is often diffuse. It is longer length. It is concentric. It is soft. It may be lipid rich in some of the histology data, and there is little calcification with poorly developed or absent fibrous cap, and usually can have a secondary thrombus over it. So due to these characteristics, it is very highly friable with the consistency of gruel or cottage cheese, with more ulceration, more thrombus, and large cavities at the site of plaque ruptures, aneurysm, and high tissue friability. We all know that the lima is largely remains free of atherosclerotic burden, but lima is not the only arterial graft which is used. We know that the radial arteries are prone to a lot of spasm, and some of the other vessels which are used, like the gastroepiploic, can have issues. Also, like I mentioned, with the lima graft, one should be careful about the left subclavian origin. Lima failures do happen, and in our context with our surgeons and with our patients, we realize that there could be some technical issues like distal runoff at the anastomosis, damage during harvesting of a lima, and also that there could be a steel phenomena from large residual branches and a distal thread phenomena which can happen. I would just like to pause for a minute here and discuss competitive flow, which is something which we don't understand very well as graft maturation. So if there is an arterial graft in place and if it has flown for about 3 months, even if there is competitive flow now, suppose you open the native vessel and there is competitive flow, when the native vessel shuts down, this arterial graft will reopen. However, if you don't have such a situation and it's a non-mature graft, then because of competitive flow, these grafts, both venous and arterial, tend to close down. So the native vessels also progress much faster in bypass patients, and this accelerated atherosclerosis occurs almost 10 times as frequently, and this can explain more fibrous, calcified, and more CTO lesions which can be here. So when we look at these lesions, we realize that a large amount of use of GPIs may not be useful in vein graft angioplasty. Access can be a challenge, and therefore the regular use of right radial may not always be appropriate. You could suggest in a more complex situation use of either a left radial or a femoral approach. As far as vein graft interventions are concerned, because of the friability and degenerated atheromatous debris, there is a higher propensity of slow flow or no reflow phenomena. One of the biggest challenges which we have when we take the patient, especially in the middle of the night, is to find the graft. And sometimes it can become a challenge to actually find the graft, especially if we don't have surgical notes. So for those who are learning, it's something which we advise always: look in RAO. Grafts which are going to be anterior are going to be grafts to the left. Grafts which are posterior are going to be grafts to the right. And normally the surgeon places the grafts to the LAD, then the diagonal, then the OM in the ascending order. But sometimes we have a challenge because when we cannot find a graft, and I myself had this problem once at 2 in the morning with an inferior MI and found that the patient had had a surgery somewhere in the United States, and it was actually a gastroepiploid graft to the right posterior descending, which had actually closed. So what about the natives? So do we always treat the vein graft? or should we always treat the native? Should we consider a staged vein graft revascularization? For example, get your job done, restore flow quickly by a vein graft angioplasty, because that appears to be a lower hanging fruit. We always know that it may not be durable. A vein graft angioplasty result may not be durable. There is a chance of an acute distal embolization and or slow flow, no reflow. We need a strong support. We need to be adept at some retrograde technologies and techniques, and we need to reach the lesion and watch for perforations. So there are some strategies to prevent distal embolization, which could be use of direct stenting, use of pre-treatment with vasodilators, undersized stents, embolic protection devices, and one-to-one sized balloons to the vein graft. Thromboaspiration may not be as effective. We do not have clear idea about the role of angiojet or penumbra in these situations. We should know how to use a distal embolic protection device because there should be adequate landing zone. Symbiote as a covered stent did not do very well. We used a few cases M-Guard, but Papyrus PK appears to be an attractive option. In 2020, we are left largely with filter wire and spider, but we must know the challenges with their deployment. So covered stents have failed to demonstrate benefit. Stent sizing, we can use 85 to 100%. Try to do a direct stenting, no use of GPIs, and look at CTOs. If there is no reflow, please do not stent. So let us look at what are the choices available other than this. Should we always use a drug-eluting stent? There is a room here of using a self-expanding stent, but the availability is an issue. You could think of undersizing your drug-eluting stent. What about native vessel PCI? Sometimes for this, you need to have additional options for going retrograde. And there are cases which we've all done. We've done staged vein graft revascularization. And for example, in this vein graft, we've come down the vein graft not to dislodge the large thrombus and conducted CTO revascularization. There could be challenges sometimes with a lot of debris, and so you can actually clear the vein graft, but again, you're scared to put in a stent because you could have more distal embolization. So go ahead and complete a CTO-like procedure by doing a native vessel angioplasty. Yes, we must understand that in post-CABG patients, it used to be thought that coronary perforations are safe. They are not actually safe. They need to be understood that there could be absence of pulsus paradoxus, there could be absence of small sign, and you can have regional tamponades in these positions. So when it comes to vein graft PCI, just don't do it unless there are no good viable native options or there are discrete lesions, and we must have access to CTO techniques to access the distal coronary bed, and because we understand that what you can't do with a stent, you can actually push a Corsair microcatheter. Thank you very much.
Thank you. Dr. Yadav, would you like to come on the video, please? That was a very elaborative talk. I think, Anil, I think we'll have the question and answer session later on.
I have actually to go into another hall, so because I have to chair the session there. But
okay. Hello, Anil. You're not audible actually. Hello. Do we have any Dr. Binoy Joy, Prasanna Kumar, Dr. Kumar Kenchappa with us, or they're not there?
I think they are not there. They have not logged in.
Right. Go on, Doctor.
Anil, just one question.
Yeah.
A lot of people are trying native vessel angioplasty in case of graft occlusion and Stemi. We have seen that people are trying practically a CTO because the graft is occluded and patient has MI in post-CABG patient. So what is your opinion regarding that?
So I think it's a very valid option because remember one thing, that even if a graft is occluded, you can safely engage a microcatheter through this graft. So what I normally do is, and we've had about 5 or 6 such cases where we passed in our Corsair and completed a reverse cart in the native vessel because then it gets us access. It also, in 2 cases, we could actually see the native vessel much better and we could do an antegrade CTO in the native vessel. This prevents a lot of distal embolization and grief because of slow flow, no reflow phenomena. However, you need to be competent and need to have the bandwidth to do a retrograde procedure or at least understand CT or PCI. Otherwise, the simplest thing would be just restore flow, even if the flow is not completely restored. Because if you try and do a high pressure dilatation, you can have slow flow, no reflow, and you can have. We have all seen cases wherein we have dislodged large amount of friable gruel into the distal circulation and landed the patient in cardiogenic shock.
Thank you.
Thank you, Anil. I think, Anil, we will let you go, and good luck with your chairing the session. That was a
Thank you.
beautiful talk.
Thank you, Rajesh. Bye, Rakesh.
Okay, bye.
Bye. We have a next talk by Dr. Keyur Parekh. Or is Dr. Parekh there, or we've changed the role of intracoronary imaging in STEMI? Dr. Jabir.
I think Dr. Jabir or is it Dr. Jabir? I think he's going to take it.
Yeah. All right. Okay. Because his name over here.
Jabir.
Is Keyur Parekh or myself?
Yeah, it's you, Dr. Jabir. It is you.
1 minute.
Go.
Let me share my screen. Can I go ahead?
Yes, please.
Please go ahead.
Thank you, Chairperson. So I'll be talking on OCT in STEMI for the next 12 minutes. Why should we do an OCT in STEMI? Because we have been doing primary angioplasty for a long time without imaging, and now why should we do the OCT in STEMI? To find out whether what is the happening to the fibrous cap. At times it is required, whether it is a plaque rupture or plaque erosion. At times it is essential to design on the management. Is it only thrombus, or is it a real lesion there? And when you see an ambiguous angio finding along with a STEMI angiography, you may have to resort to an OCT to settle what it is. And of course, for stent optimization and definitely in an acute stent thrombosis. So STEMI lesions with OCT to define whether there is a disrupted fibrous cap, is it a plaque rupture, or in some cases, could it be a calcified nodule? At times, we may have difficulty in differentiating whether it is a calcific nodule with a rupture and an overlying thrombus formation, or it's just only plaque rupture and thrombus formation, or whether it is an intact fibrous cap with OCT erosion or something like a tight stenosis, dissection, hematoma, or a coronary spasm. We did a small study with OCT in STEMI that was of 52 patients during the duration time between September to May 2018. We did a prospective observational study consisting of patients of primary angioplasty, rescue angioplasty, systematic early angioplasty, and of course a patient with STEMI late presentation who were not actually reperfused. Total number of 52 patients, we found less than half, close to 50%, 46.2% to be precise, had plaque rupture, and almost a third, a little more than a third had a plaque erosion. And one finding that we did, which was different from the other previously quoted studies, are significant tight stenosis in 17.3%. So 1 in 5 had really close to 1 in 5 had a tight stenosis. And plaque erosion was more in the fibrous plaque rather than in the lipid-rich plaque. So what we found was less of plaque rupture in the STEMI patients when compared to the previously quoted literature. And nearly 1 in 5 had tight stenosis, which was a new finding. And thin cap fibroathieroma, lipid plaque, a red thrombus was less in plaque erosion rather than in a plaque rupture. And most important, and I think the most important finding was OCT is feasible in acute STEMI. That was one thing that people worried, whether you can do an OCT in a STEMI. I'll show a few cases, a 45 years old inferior wall myocardial infarction, STEMI, and you can see the angiography showing a proximal RCA lesion as well as a lesion in the PDA, and the proximal RCA lesion looks like the culprit lesion with a plaque rupture. And the OCT, pretty large RCA, plaques here across the entire coronary tree, fibrofatty plaque as well as a plaque which is rich in lipid. And when you can see the ACR, the angioco registration, the area of interest, you can see a tight lesion with a real plaque rupture, and this patient needed a stenting. He was stented with a drug-eluting stent. Another 54 years old female with an anterior wall STEMI, she was thrombolized elsewhere, and angiography showed a borderline lesion in the LAD territory, which is starting just below the diagonal and up to the mid part of the left anterior descending coronary artery. And the OCT shows, you can see from the distal part, the triple layer vessel was seen, small plaques. Here there are fibrofatty plaques, and entire coronary tree, and here there is a deep calcium. So many areas there are plaques, but none of the plaque is critical. There is no plaque rupture, and actually the thrombus was also taken care of by the thrombolytic therapy. There is nothing, and this patient did not require an stent. So this was medical therapy for her. Another anterior wall STEMI patient, 45 years old, and you can see in the angiography there is a lesion astride the major a big diagonal. And angiography showed non-disrupted fibrous cap. The fibrous cap seems to be intact, but plenty of white thrombus with some mixture of the red thrombus at the area of this lesion. So it was an intact fibrous cap. Here also, what requires is treatment of the thrombus. The thrombus, we have to get rid of the thrombus. There is no lesion of stenting. Another anterior wall MI, LAD totally occluded. We wired, and after wiring, the flow resumed, but at the same time, you can see extensive thrombus, which was dealt with a thrombus aspiration, and then a long drug-eluting stent followed by post-dilatation. But inside the stent, you can still see there is a haziness. And we did the OCT, which showed pretty distal. The distal part of the stent was well expanded. There is no distal edge lesions, no malopposition. But at one part where there was a hazy lesion, there is a thrombus still sitting with some amount of underdilation of the stent. Here we had a problem whether to immediately post-dilate it, which can crush or rupture the thrombus, and stent again produces whether it can produce a non-flow. So we keep the patient on anticoagulation for 4 days, and then took up the patient again for an angiography. There was some amount of thrombus, but significant reduction, and a post-dilatation was done. An inferior wall, posterior wall STEMI, a dominant circumflex which was occluded, primary angioplasty done, decent flow. There was a significant lesion in the LAD territory, which we thought the LAD lesion, we will tackle it later. And this was the OCT picture of the pre-angioplasty, plenty of thrombus with a tight lesion. You can see it's a thrombus filled, but of course there is a tight lesion, seems to be a soft lesion. And 18 hours after the primary angioplasty, the patient developed a reinfarction with massive ST elevation, a low blood pressure, IABP was inserted, thrombus was aspirated, it was a stent thrombosis, and followed by an OCT. This shows most of the parts the stent was well expanded, there was no malopposition, but at the site of the massive thrombus formation, you can see some amount of under expansion, which was corrected, and thrombus was aspirated, and we could get rid of the large amount of thrombus, good amount of thrombus, we could get rid of the good amount of thrombus, and the patient could be safe. The last case, an anterior wall MI, primary angioplasty done, long lesions, so we put 2 stents with overlap, excellent response, post-PAMI, the ECG settled completely, but 90 minutes after the PCI, patient developed re-ST elevation with thrombus inside the stent. And the OCT, which showed majority of the areas the stent was well deployed, no malopposition, but at one point you can see it's not at reached that area. You can see there was some amount of under expansion. There is some amount of under expansion, especially at the area where there was an overlap of the stent, which was corrected with a post dilatation and thrombus aspiration, and the lower OCT, which shows now it's almost clear of the thrombus with a well deployed stent. And the question is, why are we reluctant in doing OCT when it is STEMI? It's a thrombus filled vessel, So we are worried whether we can get a good blood clearance. Mostly the blood clearance will be difficult, especially when it is completely occluded vessel. We pass the wire, we may have to do a balloon dilatation, but by that time the plaque characteristics will change. So the imaging has its own limitation, especially OCT has its own limitations in an acute MI. And of course, in a critically ill and unstable patient, whether to do the angioplasty and get out and get the patient stable rather than going for his imaging, that is a big question. And of course, the worry of the contrast volume, which can produce a lead on to an LV failure or acute pulmonary edema or even a renal dysfunction, a contrast-induced nephropathy. And does it really contribute to a better outcome? It of course contributes to a better outcome, not in all cases, but in selective cases. This is the algorithm. You may require intracoronary imaging for etiology, for diagnosis, whether to see the plaque is the fibrous cap is intact or the fibrous cap is ruptured, whether there is associated tight lesion or whether there is only thrombus or it's a myocardial infarction with non-occlusive coronary arteries or if it is something else. If you can identify a clear-cut culprit lesion with significant stenosis, then no doubt it is primary angioplasty. An ambiguous angiogram is another indication where we have to do a OCT or an imaging, either an OCT or of course IVS. So intracoronary imaging plays a role in STEMI. At times, it is of great help in deciding on what is the correct management strategy. So my final thoughts on the OCT in STEMI is OCT is useful in selective cases of STEMI. And the most important thing is you may be able to avoid a stent when it's only erosion and predominantly thrombus rather than a tight lesion. Of course, now the concept of whether to stent a vulnerable plaque is coming up. That's a separate issue. OCT helps when confusion regarding whether it is a thrombus or whether it's a calcific nodule. And this seems to be the best tool to optimize the stent implantation. And in acute stent thrombosis, an imaging is mandatory. And an ambiguous angiographic findings, even in STEMI, requires an intracoronary imaging, preferably a OCT. Thank you so much.
Thank you, Dr. Jabir. I think it's a wonderful talk. That's one question from your side. Do you say that OCT is mandatory in all primary PCI?
No, not at all. Never, never, Dr. Rakesh. We don't do OCT in all STEMIs. In fact, we are also a little reluctant in doing OCT. Predominantly, we do OCTs when we have doubt whether it is a plaque rupture or only a plaque erosion. And also when there is a stent thrombosis or an ambiguous lesions we are seeing in a angiography. Otherwise, routine primary angioplasty, we don't do imaging at all. Dr. Rajani, I cannot hear you.
Please unmute yourself.
Yeah, sorry. I know that Dr. Kumar is there somewhere. He's not logged in, but Dr. Kumar, can you hear us? He just sent us a chat. He's one of the panelists, Dr. John Prasanna Kumar and Dr. Kumar Kanchapar. Can you hear us? I don't think they've been able to log in.
There is a chat box. It is written, "I am here, Dr. Kumar."
That's right. That's right.
And he has written, "You don't have a mic."
I don't have a mic now. Well, it's okay. No, so basically, this was a wonderful talk, Dr. Javed. I just, when you have a PAMI, you have got so many things happening at the same time. The utility of an extra tool, I don't know whether the p-value is going to be really significant even when you do it. Really, I don't know what the future of imaging is going to be as far as PAMI is concerned. Maybe over time, probably with the user friendliness, things might change. But I don't know whether in 100 out of 100 cases, I'll be probably applying it maybe in one only. What do you have to comment on that?
I fully
what is
agree.
your comment on that?
We may not be using imaging, especially OCT in large number of cases of STEMI. One is limitations of the imaging, limitations of OCT in a patient with a total occlusion of the vessel with a large thrombus burden. There are only selected cases, especially patients with an acute stent thrombosis, patients where we suspect a plaque erosion. These are the two situations where I think an OCT is going to help. And I fully agree with you that maybe perhaps at 10% or 5% of the cases where really an OCT is indicated, and we have to do an OCT. we'll be compelled to do that.
Thank you. Dr. Kumar is here. Dr. Kumar, can you hear? Do you please put on your video if you want to ask any questions. Well, I think I think we can. Sorry. Hello.
Dr. Sajan is here?
Yeah. Yes.
Yes.
Acha, Dr. Sajan is here.
Yeah.
Please.
I think we can proceed on with the next talk, Dr. Yadav.
Yes, sir, please.
Of course. Dr. Sajan
Raja.
Narayanan.
Yeah. If my slides
Over to
are
you.
visible now.
Yes, sir,
Yes, sir.
visible, very much.
Absolutely.
Good afternoon to all panelists and colleagues. The title of my presentation is Physiological Assessment During Stemi Interventions. From the three large important trials which has been published over last 2 decades, it has been found that FFR cutoff of 0.75 to 0.8 clearly discriminates patients who are at risk of events versus those who can be safely kept on medical follow-up. In DIFFER trial, patients with stable coronary artery disease who harbored lesions of intermediate severity on angiogram, when they were deferred based on FFR of more than 0.75, the freedom from myocardial infarction at 15 years was significantly less when compared to those patients who are an FFR of less than 0.75. In FAME trial, when patients who were randomized to FFR-guided PCI and who had an FFR of more than 0.8 and were subsequently kept on medical follow-up, the incidence of myocardial infarction at 2 years was 0.2% and need for repeat revascularization was only 3.2%. In FAME2 trial, those patients who were randomized to PCI versus medical management based on FFR of less than 0.8, when they underwent revascularization, the need for MACE was at 5 years was significantly reduced in revascularization arm when compared to medical management arm. And this was driven primarily by reduction in the need for urgent revascularization. So these 3 trials proves two very important points. One, it is very safe to defer a lesion if the FFR is more than 0.75 to 0.8. And if they have an FFR of less than 0.8, they may derive benefit from revascularization. But these 3 trials excluded patients with ACS, especially the DIFFER trial clearly excluded patients with ACS, but FAME and FAME2 included patients with ACS about 5 to 7 days after the index era. So whether these results are applicable in the context of STEMI is an important question. We have a sub-analysis of FAME trial which analyzed the event according to the entry diagnosis. Those patients with unstable angina or non-ischemic who underwent FFR-guided PCI derived same relative risk benefit. But in absolute terms, the event rates was close to 24% when compared to 17% in patients who underwent FFR-guided PCI with an entry diagnosis of stable angina, confirming that patients with ACS are a high-risk subset who are at risk of increased incidence of MACE. Now we'll come to physiological assessment of culprit lesion in STEMI. Whether the FFR cutoff of 0.75 is still relevant in assessing a culprit lesion. And this is an important paper which was published by Bernard Debryan and his colleagues in Circulation. They included 57 patients about 6 days after STEMI and tested whether FFR of 0.75 correlates with SPEC findings. And found that the FFR of 0.75, the concordant rate with SPEC finding was close to 85%. And if you take true positive SPEC, that means those patients who had a positive SPEC before PCI, which reverted to negative after successful PCI based on FFR of less than 0.75, the concordant rate was close to 94%. So in true positive SPEC cases, they had a better ejection fraction and lower FFR, confirming that for the same degree of diameter of stenosis, confirming that the FFR cutoff of 0.75 in the context of culprit lesion assessment of STEMI identifies patients who are a harbor of significant amount of viable myocardium and who may derive benefit from revascularization. But this particular study was very small, included patients with single vessel disease and included infarct artery of at least 2.5 millimeter in diameter. We know that in the context of STEMI, there is a lot of embolization, endothelial swelling, microcirculatory rarefaction. Whether the microcirculatory reaction to hyperemic stimulus will be same in all cases. This is an important data from OX-AMI trial, which looked into the microcirculatory parameters at the time of primary PCI and day 1 and at 6 months at follow-up. And they assessed mean transit time, coronary flow reserve, IMR, and FFR. And they found that baseline mean transit time, there was no difference at 6 months. But hyperemic mean transit time was significantly reduced at 6 months when compared to assessed at primary PCI. And this is reflected in CFR and IMR values. CFR was 1.8 at the time of primary PCI, which rose to 3.2, and IMR fell from 37 to 24. And this is reflected in FFR values also. The FFR value was about 0.02 units lower when assessed at 6 months, confirming that the microcirculatory stunning is a real concern, and the microcirculation progressively recover and they start responding better to the hyperemic stimulus as the time progresses. And this is another data from Oxford Heart Center, which showed that the IMR, which is calculated as a distal pressure multiplied by mean transit time, if you have an IMR of more than 40, that predicts a larger infarct size at 6 months and a poorer prognosis. So in short, when assessing a culprit lesion in the context of STEMI, hyperemic indices may not be reliable. But IMR of more than 40 has a prognostic value which predicts a larger infarct size at 6 months. Now we'll assess we'll see how physiological assessment of non-culprit lesions fares. This is a real-world case which I had an opportunity to manage. This is a 57-year-old gentleman who presented inferior wall acetylation MI in September 2018. He presented late. He had a borderline lesion in the proximal LAD, and the FFR of LAD lesion was 0.82. So he was advised to continue antiplatelet statins and secondary prophylactic measures. About 15 months later, he presented with chest pain and ST elevation in the anterior leads, and he had an ST elevation MI in the anterior territory and underwent primary PCI to LAD. So what is the safety of deferral of FFR? Whether the FFR cutoff of 0.8 is still relevant in assessment of non-culprit lesions. We have data from Dynamic 3 pre-multi where patients with undergoing primary PCI were randomized to, who harbored intermediate lesions in non-culprit lesions were randomized to FFR-guided PCI versus medical management. Those patients who underwent FFR-guided PCI had a better outcome. And in subset of patients who had an FFR of more than 0.8 who are deferred had an outcome similar to those patients who underwent PCI, but the absolute number was close to around 90 patients. But in compare acute, those patients who harbored intermediate lesions in non-infarct radial artery, all the patients underwent FFR. And one group underwent FFR-guided PCI, other group, they didn't do anything. And those patients who underwent FFR-guided PCI had a better outcome, which was driven primarily by reduction in the need for urgent revascularization. And an FFR substudy of compare acute showed that there is a gradation of events as you compare the tercels of FFR, which is in contrast to what is seen in stable angina, where FFR cutoff of 0.8 clearly discriminates patients who are at increased risk of events versus those who are not. And this is seen in patients in a single center experience in Veterans Affairs study also, where patients who were deferred based on FFR cutoff of 0.75 in the context of non-acetylation MI. You can see that there's a clustering of events in FFR, gray zone FFR and borderline FFR. And the investigators proposed that in the context of ACS, the line may be drawn a little further, that is about 0.84 for better discriminative value and safety of deferral. And why this happens? We have analysis from reduced MVI trial where they analyzed the microcirculatory reactivity of non-culprit lesions at acute moment and at follow-up at 30 days. You can see that the aortic pressure doesn't show much change, but the distal pressure, there is a significant change of 4 millimeters of mercury at follow-up. And this is reflected in CFR, which showed significant increase, and FFR, which showed significant reduction when assessed at 30 days. IFR also showed some change, it increased, but it didn't reach statistical significance in this particular study. If you see the acute moment IFR and follow-up IFR, the classification agreement was close to 82%. But there were more cases of IFR cases. About 23% of the patients had IFR of 0.89 when assessed in the acute phase. But this figure was 19% when assessed in the follow-up. The converse was true for FFR. About 15% of the patient had FFR of less than 0.8 at the acute moment, but this figure rose to 26% at follow-up, confirming that acute IFR tends to overestimate and acute FFR tends to underestimate the significance. And this is seen in iSTEMI trial also. You can see that about 24 patients out of 147 had an acute IFR of less than 0.9, which had a follow-up IFR of more than 0.9. So the classification agreement is only moderate. And we have combined analysis of defined flyer IFR sweetheart, which looked into what is the safety of deferral of lesions in non-culprit vessels based on FFR cutoff of more than 0.8 or IFR cutoff of more than 0.89. There was no difference in the event rates based on the FFR or IFR cutoff deferral. But in absolute terms, when you compare with the entry diagnosis of stable angina, the MACE events was 5.9% versus 3.64%, which is equally observed in FFR and IFR arms. And we have pooled analysis of 5 studies, that is R3F, POST-IT, IRIS FFR, which are registry data, and defined flyer IFR sweetheart. You can see that those patients who have an entry diagnosis ACS, and if you defer a non-culprit lesion based on FFR of more than 0.8, there is increased risk of MACE, and the curves separate as early as 30 days after the index event. So in short, so this is data on non-invasive FFR, what is the diagnostic performance of non-invasive FFR in the assessment of non-culprit lesions? You can see that the specificity is 66%, sensitivity is 83%, which is significantly less as compared to the performance of FRCT in the context of stable CAD, where the reported specificity is close to 85% in the next trial and Scott Hart trial. So in short, FFR of less than 0.8 identifies non-culprit lesions who may benefit from PCI. But the safety of deferral based on FFR or IFR cutoffs remains to be proven, and there are real concerns. The diagnostic performance of non-invasive FFR is low at this point of time. So this is a algorithm which has been put forward. If you have if the patient undergoes primary PCI, if you have non-culprit lesions with FFR of less than 0.8, the person should undergo revascularization. The data is robust. But if FFR is more than 0.8, now the data is emerging that imaging may be providing more prognostic value or more discriminative value in safely performing PCI versus deferring the lesions. If your person undergoes thrombolysis or person is late, and if you have a culprit lesion which appears borderline on angiographic analysis, and the FFR is less than zero point 0.8, the person should undergo revascularization. But if the FFR is more than 0.8, that person should undergo reassessment at 6 months. Thank you. Thank you for the patience.
Thank you, Dr. Sajan. I think it's a wonderful talk. And if should be, if, I think there's no question in chat box. In hello. I think we should. There's no question in the chat box, and I think we should move to the next topic, which is. I think there's still time for debate. 4:35. I think we have plenty of time to discuss these three talks. Dr. Kumar, are you able to? You have posted one question, I think so. Hello.
Sir, am I
Any
audible,
more
sir?
questions?
Am I audible?
Any more questions?
Am I audible, sir? Dr. Kumar here.
Yes, clearly audible.
Sorry for joining late. There was some issue with my mic and these things, sir. Sorry.
If anybody has any question for these three speakers, I said Dr. Anil Dhal has left, but Dr. Jabir and Dr. Sajan is very well here.
So, when is it ideal to do if there is an acute MI? So, how long do you wait for to do an FFR if there is a second lesion?
See, if the person has a non-culprit lesion which appears to be borderline, now the compare acute has assessed the FFR on the time of procedure, and dynamic 3 pre-multi has assessed FFR about 2 to 3 days after the event rate. Now we have data, and the ACCHA appropriate usage criteria has given highest recommendation, that is about 7 points for in-hospital assessment of non-culprit lesions and revascularization based on FFR of less than 0.8 during same admission. This criteria came out in 2017. Now we have data emerging after that, if you have an FFR of less than 0.8, there is no doubt the person will benefit from revascularization. But especially if you have a gray zone or borderline zone FFR, then you have a problem whether to undergo, whether subject to patient for a optimal medical management or whether the patient should undergo PCI. So this is an area where a lot of studies are, a lot of concerns have been raised, especially after the publication of recent data from 2018. So what I personally feel is that if you have a gray zone FFR or borderline zone FFR, that is between about 0.75 to 0.8, those 0.82, that those borderline and gray zone FFR, it is better to keep a patient on medical follow-up and subject him for a repeat procedure or even a non-invasive assessment like a stress nuclear scan or something like that after 30 days. Because the event rates in this population is very high in the first few days.
Thank you, sir.
I think we are not seeing any question in the chat box. So
yeah, I know.
Then we should move to the
So,
hello.
Yeah, I think we can move on to the next session if
Yes,
Dr.
sir.
Rajpal and Dr. Arun Gopi are there. Dr. Gopi is here. Uh, Dr. Rajpal is not over here really. So
Dr. DP Sinha, I think it
if he
is.
was there,
New is the Dr. DP Sinha. Yes. Dr. DP Sinha is
oh
here?
no,
Okay,
I think.
okay, Dr. Yadav,
Acha,
I'm here.
yeah, he's there.
yeah,
He's
acha,
there.
yeah, yeah.
He's there.
So I think we are going to have a very interesting debate. And recently there's a lot of discussion on prasogil and recent evidences that prasogil is even better. And so in Indian setup, I think prasogil is a cheaper, it's an OD doses. So this will be going to be a very interesting debate that whether we should stick to our ticagrol or new evidences toward the prasogil. And there's two very learned speaker. Arun Gopi is a very good speaker, and Dr. DP Sinha. And both we are given 7 minutes each. Kindly restrict to the time because it is a debate, and a rebuttal for 2 minutes each. So, Dr. Gopi, should you start the first thing, which P2Y12 inhibitor in ACS? And Dr. Arun Gopi will talk on favor of ticagrol, and Dr. Sinha on prasogil. Please.
Respected chairpersons, colleagues, a warm good evening. At the outset, I thank the organizers for the opportunity to discuss the backbone of management of acute coronary syndromes, that is antiplatelets. So we all know that platelet activation and aggregation forms the crux of problem in acute coronary syndrome, and so antiplatelet therapy forms the cornerstone of management of acute coronary syndromes. For years together, we were doing this with aspirin and clopidogrel along with the parental 2B3 inhibitors in high-risk patients. But we clearly know that clopidogrel has its own limitations. It's a prodrug which has a slow onset of action. There's because of the pharmacogenomics involved, there's higher individual variability in the response. It's an irreversible inhibitor with just moderate level of platelet inhibition, IPA levels of 55%. And Asians, unfortunately, have a higher prevalence of loss of function gene, and that is why if you look at most of the studies across the globe, we find clopidogrel resistance to the tune of 5 to 44%, and that is why you have increased MACE in clopidogrel non-responders. So we clearly needed an alternative to clopidogrel, and that's what we are going to discuss in this current debate, whether it is ticagrelol or prasogil. The benefits of ticagrelol starts from its mechanism of action, from its pharmacokinetics itself. It's a non-thionidopyridine ADP blocker. It's a reversible blocker. It's a directly acting, highly selective P2Y12 inhibitor, which has quite a rapid onset of action. It's a very potent antiplatelet with the highest level of P2Y12 inhibition known to date. It has rapid reversal of effect. It has uniform effect. That is why you don't find inter-individual variability of effect. It gives adequate platelet inhibition, which is maintained on the long-term follow-up as well. So starting from the pharmacokinetic advantage of ticagrelol over prasugrel, ticagrelol is a directly acting agent, so that is why you have onset of action as early as 30 minutes after 180 mg bolus dose of ticagrelol. It's a reversible blocker, so that's why you have rapid offset of action. The moment you want to send the patient for a CABG or a non-cardiac surgery, just withdrawal of drug as short duration as 72 hours is sufficient for offset of action of ticagrelol. On the other hand, prasugrel needs to be stopped for as long as about 7 days. It's a very potent ticagrelol is a very potent antiplatelet drug with an IPA levels of more than 80%. And to date, we don't have any data on non-responders as we have with clopidogrel. And this is all the testimonial of all the advantages is shown in the Plateau trial, which showed 21% relative risk reduction on cardiovascular mortality on combining ticagrelol 90 mg with aspirin, and the benefit started quite early and was maintained throughout the year. And at 1 year follow-up, a 1.9 absolute risk reduction of cardiovascular mortality was seen. And now we have data which shows that the benefit of the drug even extends beyond 1 year with the data from Pegasus Stemi 54 trial, which says ticagrelol 60 mg combined with aspirin shows a significant reduction of cardiovascular events without increased risk of bleeding. So would you not prefer an agent which can be continued for as long as duration of 3 years, and the benefits of which are well proven not only in trials but also in the real world outcomes like the Swedheart and Denmark registry, which have data from close to 40,000 and 60,000 patients in these registries, which clearly echo the results that were shown in Plateau and Pegasus Stemi 54, showing clearly an agent which has more effect and clearly safe. And why we say safe, if you look at Plateau as well as Pegasus Stemi 54, the major bleeding was not increased with ticagrelor compared to clopidogrel. That is where ticagrelor actually has a clear advantage over prasugrel, because prasugrel, if you look at Triton Temi 38, it has clearly increased efficacy, but all this increased efficacy comes at a cost of increased fatal bleeding, and that is significantly increased in prasugrel compared to clopidogrel in Triton Temi 38, but in Plateau we didn't find increased bleeding with ticagrelor. And that is why the manufacturers itself gives a black box warning with prasugrel. That is, you should be careful when you're using prasugrel in people who are less than 60 kgs, people who are more than 75 years, who it's absolutely contraindicated in people with history of stroke or TIA. And if you want to plan CABG or non-cardiac surgery, you have to wait for at least 7 days after prasugrel. On the other hand, with elderly patients, ticagrelor is absolutely safe, as shown in the Plateau elderly sub-study, which shows that irrespective of the age, ticagrelor is extremely safe, no increased risk of bleeding. Now, what about patients who are lysed? All acute coronary syndrome patients don't go to the cath lab. Some of them are thrombolized, and we have data from TREAT trial which shows that ticagrelor is extremely safe in patients who are thrombolized with no increased risk of bleeding. On the other hand, with prasugrel, the Triology ACS trial, we know that in acute coronary syndrome patients who are managed non-invasively, prasugrel has increased risk of bleeding and does not have any significant benefits. Now, when you look at the most hard endpoint, we all want our patients to live longer. The hardest endpoint is mortality. So the only P2x12 inhibitor which shows mortality reduction is clearly ticagrelor, with a 21% cardiovascular death reduction with ticagrelor and a 22% all-cause mortality reduction with ticagrelor. Also a 16% reduction in myocardial infarction. On the other hand, prasugrel only reduces myocardial infarction. There is absolutely no mortality reduction with prasugrel, either cardiovascular mortality or all-cause mortality. So when you're looking at acute coronary syndrome patients, do you want to think of the pros and cons, and do you want to really think on what agent to use? Clearly, ticagrelor is the holistic solution, because you can use this agent in any form of acute coronary syndrome patients, whether it's an unstable angina patient, whether it's non-ST elevation MI, or it's a STEMI patient. You can use irrespective of the treatment protocol you're going to follow, whether you're going to lyse the patient, whether you're going to take the patient for cath lab, or after a coronary angiogram, you're going to send him for an early surgery. Irrespective of the treatment strategy you're going to follow, you can use ticagrelor. And irrespective of the patient characteristics, whether there is a history of TIA or stroke in the past, whether the patient is thin and lean or the patient is elderly, you don't have to think of the patient characteristics. Ticagrelor is clearly a universal antiplatelet which can be used. On the other hand, prasugrel can only be used in patients who are going for PCI but at the risk of cases of bleeding. That is why if you look at the guidelines give a class 1 indication for ticagrelor to be used for 1 year. There is a class 1 indication for treatment for patients with acute coronary syndrome in the PCIM, as well as patients who are treated medically. Also, there is a class 2B indication for use beyond 1 year as well. In the ESA guidelines, you can use ticagrelor after 1 year from taken evidence from the Pegasus Stemi 54. So to conclude, respected chairpersons, when you are dealing with a person, a sick person like having acute coronary syndrome, would you not use an agent which has a very rapid onset of action being as early as 30 minutes? Would not use an agent which is extremely potent, which is extremely safe, no increased risk of bleeding. It has a quick offset of action. So you want to send him for an early cardiac surgery, you can stop the drug for 72 hours and just send him for a surgery. You can use it irrespective of the treatment protocols you're using. You can use it safely in patients who are lysed. You can use it in patients who are going to go for surgery or even going to the cath lab. And we have data now to say that this is safe even after 1 year of acute coronary syndrome. And this is the only agent which has shown to have mortality benefit. On the other hand, prasugrel can only be used in patients in whom the coronary anatomy is known, and even in these patients, it comes at increased risk of bleeding. Not safe in elderly lean patients or patients with prior history of CVA or TIA, and not safe in lysed patients. And this agent does not have any mortality benefit. I'm sure my Dr. Sinha is going to talk on ISAR React 5, which was the latest trial, which Dr. Rakesh Yadav also alluded to, and I'll take that in the rebuttal session. So I rest my debate here with all things in favor of ticagrelor, and I'll take on ISAR React 5 in my rebuttal. Thank you.
Thank you, Arun. Wonderful starting of the debate in favor of ticagrelor. But before we came with any conclusion, I think we should hear Dr. Sinha, who will be speaking in favor of prasugrel. Dr. Sinha, please.
He has to unmute actually.
You're on mute, Dr. Siddhant.
Sir, can you hear us? Can you hear me? Sorry.
We can hear you.
Am I audible?
Yes, yes.
First of all, I want to thank the thanks Professor P.P. Mohammed and Dr. Dani for arranging such an excellent meeting in an extremely challenging situation. And to Dr. Papi, who presented his test very nicely. In fact, it was too nice. My brief is that Prasugrad is my choice. Why? Sorry, can you go back? Go back.
Oh, sure. So once again, sir.
Sorry. Can you stop the clock?
The clock, reset.
Okay. No. Prasugrad is my choice. In acute coronary syndrome, the first agent that should be used is aspirin, which was touted as does not affect heart. And it is written in stone that in patients with acute coronary syndrome should receive 2 tablets. The Propitical was the basic first thienopyridine that was used in patients with acute coronary syndrome. But with time came Triton 38 and Plato, in where Prasugrad and Ticagrelor both showed benefit over Propidocel to a similar level. But what about the selection between these 2 agents? Which one should be selected? There is only 2 head-to-head trials, despite what Dr. Kopia said. Only 2 head-to-head trials. The first one was the Prague-18 study that was published in 2016. It was an open-label randomized trial. It was terminated early because only 1,230 patients were randomized. Nearly only half of those died because of futility. But the head-to-head comparison of Prasugrad and Tica does not support the hypothesis that one is more effective or safer than the others in preventing ischemic or bleeding events in the acute phase of acute myocardial infarction treated with a primary fitness coronary intervention strategy. This is the 30 days follow-up. And if you look at the subgroups, all-cause mortality, cardiovascular mortality, myocardial infarction and stroke are similar between Prasugrad and Tica. Although the Prague-18 trial was the first time to perform a head-to-head comparison, it was significant limitation. Number 1, it was prematurely terminated, and number 2, high rate of switching to Propidocel from the assigned groups impeded true comparison between the drugs over the column. Then in 2019, NICER React 5 trial was published. And this is a peculiar problem in this trial, that the sample size was calculated on the assumption that the incidence of primary endpoint will be Tica. Tica will be superior and will be higher in the Prasugrad group. And even in the Tica group, it was pre-treatment was in all patients in the Tica group and no pre-treatment in the Prasugrad patients who had an acute coronary syndrome without ST segment elevation. So that the loading dose was given to fewer patients in the Prasugrad group than in the Ticagrelor. So this is the flowchart of the patient recruitment, and this is the demographic of the patients. Both are similar in the 2 groups. But when you look at the results, please note that the primary endpoint surprisingly came out in favor of Prasugrad group rather than in the Tica group, which is very significant. And the bleeding endpoint, which has been so much hard on, didn't differ between the 2 groups, but type 3, 4, or 5 bleeding. If you look at the curves of efficacy kept on separating beyond 1 year, but the bleeding curves were similar in both the groups. And the safety endpoints were similar in the 2 groups. So what is the conclusion? Conclusion was that the prasugrel significantly, the primary composite endpoint of death, MI or stroke was significantly lower amongst patients who received prasugrel than amongst those who received TICA. If you look at the subgroup analysis, when the patients who are treated of ST segment elevation were treated with either prasu or TICA, there was no significant difference between prasu or TICA. And in the patients with diabetes, in fact, in patients without diabetes, prasugrel was equivalent to TICA, but in patients with diabetes, prasugrel was better than TICA. If you look at the meta-analysis of the different data of different safety and efficacy of prasugrel and ticagrelor, several meta-analyses have been published in the past 1.5 years. In American Journal of Cardiology 2020, at 30 days, prasugrel was associated with significantly lower rates of MACE and mortality. At 1 year, mortality still favored prasugrel. But if you look at another meta-analysis published in the year 2020 March, JAC, this meta-analysis showed no difference in the outcome between TICA versus prasu in patients with ACS or whom PCI was performed. And another meta-analysis again published in Circulation, it was the network meta-analysis of all three, clopidogrel, prasugrel and TICA. In comparison with clopidogrel, prasugrel reduced myocardial infarction, whereas ticagrelor showed no risk reduction. If you look at the price and the resource utilization because of repeated hospital visit, because of shortness of breath, resource utilization was higher in the patients treated with prasugrel. That is why in 2020 ESC guidelines, prasugrel has been given preference over TICA for NSTSC patients who proceed to PCI. Thank you.
I think Dr. Gopi, you have a lot to rebuttal against Dr. D.P. Sinha. So please, your time of rebuttal starts now.
Yeah, Sinha sir has well alluded to the benefits of prasugrel over ticagrelor, but most of the slides, if you see, he had shown that most of the, there were confusion in the meta-analysis on whether prasugrel is really superior over ticagrelor, and the guideline that he last quoted, the ESC 20 guideline, had a controversial statement. In fact, it favored prasugrel over ticagrelor, but unfortunately, this is solely based on one single randomized control trial, that is ISAR-REACT 5. And the whole discussion of my rebuttal is on ISAR-REACT 5, which was an investigator-initiated phase 4 trial, which found all the difference or all the things in favor of prasugrel to clopidogrel. But unfortunately, we should realize that this trial was just conducted in 2 countries, 21 centers in Germany and 2 centers in Italy participated, with a significant risk of recruitment and observation bias that was there. Of the patients who were randomized in the trial, discharge on the assigned study treatment was in only 80% of patients assigned to ticagrelor and 80% of patients assigned to prasugrel. So 20% of the patients each study arm did not receive the assigned treatment. At the follow-up, you find 35% of patients in the ticagrelor arm and 31% in the prasugrel arm did not receive the study treatment. So the whole analysis comes because we follow the intention to treat analysis, and that's when we include the 1,300 patients who dropped out of treatment, that is when we find the significant difference. If you take the patients as per what treatment they took, that is what treatment they adhered to, the significance were not different. It was not statistically significant. And if you look at the median time to discontinuation also, people on ticagrelor discontinued drug earlier. The median duration of discontinuation was 84 days versus 109 in the prasugrel arm. That is why you had higher events rate in patients who were on ticagrelor. And there were a lot of patients who were excluded from safety analysis as well. 11% of patients in the prasugrel arm were excluded from the safety analysis. On the other hand, only 1% was excluded from the ticagrelor arm. And the whole trial was continued for a prolonged duration of 5 years, and during which time we all know that the clinical practice would change. And that is why without consecutive enrollment, it is not possible to exclude some form of recruitment bias that would have, which would have came in this study. And just one more study to conclude off. Actually, a platelet reactivity analysis in diabetics with ACS found that residual higher platelet reactivity was in fact seen in insulin-treated diabetic patients in prasugrel, but absolutely no residual platelet reactivity was seen in the ticagrelor arm. So ISA-REACT was actually a fallacious trial which had a lot of patients, about 1/3 of patients not adhering to the treatment that they were assigned to, and only the intention to treat analysis actually brought forth these results. So I would say that just residing on the ISA-REACT 5 trial alone would not be tried.
We have still a lot of time, so we can give Dr. Sinha to rebuttal for 2 minutes.
Yeah, I would like to have the chance.
Absolutely.
As per Dr. Gopi's own admission, prasugrel and ticagrelor were similar in efficacy. Now, even without considering that point, I just want to make one observation. Prasugrel is half costly than ticagrelor. So far as I am concerned and my patient is concerned, I will certainly think out prasugrel. Number two, he has talked about bleeding, elderly, low weight. You reduce the dose half. That has been accepted that you could reduce the dose by half. It doesn't cause that much of a serious problem. Yes, severe is a problem. You have to omit prasugrel. Number three, in medically treated patients, I do not think there is convincing data as of now that either prasu or ticagrelor is of any benefit for much longer. Number four, for prolonged period of treatment, the benefit is always bought at a cost of hemorrhage. Whatever the therapy you use, buy it at the cost of hemorrhage. So that the current thinking is this: how do you reduce the duration of two antiplatelet agents in therapy, where various trials are underway? Either you go short, you go long. But certainly people are veering towards a shorter period of study. So that yes, it is safe, potent, cheap, and of course it is effective than ticagrelor. And lastly, this high platelet reactivity, it is still in the research stage. Still as a class 2B indication that if you have got some problem, you can try, but it is not an absolute indication till get high platelet reactivity.
I think after this good debate, we have still ample time to discuss this issue. Before going to raise hands in favor of Dr. Arun or in favor of Dr. Sinha, I think in virtual it will be a very difficult thing. But I can ask the chairperson and panelists because we have about 15 minutes left. So Dr. Rajesh, hello. I think Dr. Kumar, Dr. Mantosh Panja is here.
I told you in the last one.
Yes.
Sir, just 1 minute about your comment because we have 15 minutes time left in this session. Still, we have a lot of time.
Yes, thank you very much for asking the question. In day-to-day life, really, 90% case I used to use the ticagrelor, to speak. On certain situations, and I used to only prasugrel. But sometimes the more bleeding, I actually use the 5 milligram that situation. So that is my comment. Dr. Sinha has rightly pointed all the pros and cons of prasugrel and well appreciate.
But my comment after listening the two learned speakers, I will still say the evidence is not that prasugrel is better than ticagrelor. The evidence at present is now prasugrel can be given in ACS because initially it is very clear the prasugrel should not be given until you know the coronary anatomy. But at present, I think the evidence in favor of prasugrel is that prasugrel is not as bad as was presumed before. But I is still not convinced that it is better than ticagrelor. Overall cost of prasugrel is much less. But now when the ticagrelor goes off patent, I think the issue of cost also goes away. So, except in my view, I will still say the evidence are not in favor of prasugrel too much that it is better than ticagrelor.
Yeah, can I make a comment?
Please,
Yeah,
please, Dr. Sinha.
yeah. Regarding the second part of your comment, the cost, even with both Prasu and Taika has both gone up patent. And even with an off patent price, it is still half of the price of Taika. Still half. A tablet of Prasu, different generic brands will cost you around 20 to 23 rupees. And Taika will be around 40 to 50 rupees, somewhere between 40 and 50.
Dr. Rajesh, we have still plenty of time left in this session.
Yeah.
So, what
Ji.
is your comment? We
Well,
have
I
learned
think,
the
yes, absolutely. No, I had this call from the casualty, so I'm sorry about that. But I think I would prefer a drug which has got versatility and malleability. I mean, with all due respects to the speakers, Tika is a very versatile drug in the sense that, you can use it in any age group. Basically, of course, the bleeding risk nearly remains the same with both. You can use it in the coronary artery anatomy, which is not delineated. You can use it. If there's need to stop the ticagrelor, you can the effect goes off very fast. So I feel it's much more a versatile and a much more malleable drug as compared to prasugrel. Of course, cost definitely is a factor over here, but I'm sure that should not be of a concern. This is my personal opinion, really. I mean, as far as diabetics are concerned, of course, renal friendly also at the same time. The patient's got CKD or any form of renal dysfunctions and things like that. It's a good drug, of course. Both the drugs have their side effects. Tika has got the side effect of, hyperventilation and breathing disorders and, bleeding and bradycardia and things like that. But I think overall, if you tell me to pick up, I would pick up Tika.
Rakesh, on my question, in
please.
case of the ticagrelor, you can continue long-term follow-up to 3 years, 60 milligram twice daily, and the Pegasus trial shows there is no difference 90 to 60. I want to talk to Dr. Sheena, how long you can continue long-term follow-up period?
Sir, I have already pointed out that long-term safety you buy at long-term use you buy at the cost of bleeding. So that if you cancel out the bleeding part, doesn't really make much of a difference.
Can I add a point, sir?
And
Yeah.
possibly there is scant data about long-term use. I think data is coming up. But
Yes, Dr. Gopi, please.
Yes, sir. In the Pegasus Stemi 54, in the long term, up to 3 years, it's efficacious and no increased risk of bleeding. So on long term, there's no increased risk of bleeding. It's very safe and it gives a reduction of acute events as long as 3 years. So you would prefer an agent which you can continue on a long term benefit, especially in high risk patients.
See, the ISR React 5 is little difficult to believe in a biological way, because you have a drug which is reducing the ischemic events better, but on the top of the point you have a reduction in the bleeding also, because all those trials which have a better platelet inhibition should have more bleeding. So that is not seen in the case of ISR React, which we are missing some point, I think. Because see, any drug which has better platelet inhibition should have more bleeding, because it is an extension of pharmacological effect. And we have in ISR React 5, there is one paper which mentions about reporting bias, because being an open label trial, patients, the treating physicians were more aware of the bleeding side effects of ticagrelor, and the small bruises, ecchymosis were more reported in the ticagrelor rather than the prasugrelor. So that must have also contributed to what is the difference in the bleeding events in either of the arms, I believe. There was one.
I think we are reaching to the time limit which we were given for this session. And in the last comment, I will still say that still it is a debatable topic. There is no final answer, but the general census is in favor of ticagrelor. However, few can say that prasugrel is coming very well and might be in near future. If you have a good evidence, you can say it is equal to ticagrelor. But still, the general consensus is in favor of ticagrelor. I think we should thank everybody for joining this session, and we are approximately 30 seconds left for this session. Thank you very much.
Thank you, sir.
Thank you.
Thank you.
Good evening. I am Dr. Sharad Jain from CSI 2020 from Ahmedabad studio. So the next session is BC Roy Oration. I invite Chairperson Manchanda SC, Mantosh Panja and Ashokan Nabiyar. The speaker is Venkata Ramsi, my nearly 4 decades of journey in the field of hypertension. So over to the chairpersons.
FRCA MRCP. He born on July 1982 and demised on 1st July 1962. He was the eminent Indian physician, educationist, philanthropist, freedom fighter, and politician. He was the Chief Minister of West Bengal 1948 to 1962. He is a marker of modern West Bengal. The National Doctor Day is celebrated on his memory. And he was the founder president of Cardiological Society of India 1948, and he was the founder president of Medical Council of India. This oration is dedicated on his memory by Cardiological Society of India. Thank you very much. I request Dr. Venkatram, actually Manchanda, to introduce the Venkatram.
Thank you, Mantosh. Well, welcome to this most prestigious oration of Cardiological Society of India. As you heard, Dr. B.C. Roy was the founder of Cardiological Society of India, and in his memory this oration has been kept. And to address, it is none other than Dr. C. Venkatram, who is known not only nationally but internationally. I call him the living legend in hypertension. Actually, he brought the specialty of hypertension to this country, and he has really changed the outlook of people as regards hypertension, because hypertension was considered as a very unimportant subject, and he has brought the importance of this, and he has now so many followers that many of my students want to become hypertension specialists and all. So Dr. Venkatram is one of the really, I said, living legends in the field of hypertension, and he is going to talk about his experience of last 40 years. I think one of the very few people who specializes in hypertension, and he has a vast experience not only in this country but also in the United States, where he is still working at present. I'm told he is still in Dallas. So over to you, Venkat.
Yeah.
Okay, can you see the slides?
Not yet.
Not yet.
Can you see the slides?
Not yet, not yet.
Oh.
Is Anand, please take care.
Share or something.
Okay.
Okay, just hold on.
We can hear you all right, but we can't. Yeah, we
can you see the slides now?
Yeah, we can see it now.
Okay. All right. Can I start?
Yeah, please do. We can see very well.
Okay. Good evening, ladies and gentlemen. Greetings, my best wishes and my support to all of you at the CSI and people who are participating. The great characteristics of Dr. B.C. Roy have already been enumerated so beautifully by Dr. Mantosh Panja. I don't know whether in the current environment, any of us could actually emulate Dr. B.C. Roy totally. But I think if we take some aspects of him as a humanitarian, we will be fulfilling his dream of an ideal doctor. I also heard that when he was the Chief Minister of West Bengal, he was actually seeing some patients also at the same time. So clinical medicine is a fantastic opportunity we have. And in fact, I enjoy medicine because of interactions with the patients much more and how much trust they have, and we need to return their trust. And thanks to Dr. B.C. Roy, that he keeps reminding us daily that we need to honor the trust that the patients have in us. So let me go through some of the highlights during my own 4 decades of experience in hypertension. And each slide I am going to show is from my publications, and there is a publication citation, so that if some of you are taking any pictures, that is a citation from which I am going to discuss. These are 3 individuals that I have to thank for permitting me to advance my career. And of course, Dr. Norman Kaplan, all of you know, under whom I worked for a long time. And these 2 other gentlemen were the chairman of the Department of Medicine at the institution where I was. And one, Dr. Sheldon here in the white coat, he used to come at 8 a.m. and go home at 6 p.m. until the age 97. Until age 97, that was his schedule. So these are the people whom we need to follow and work as hard as possible. And I'm grateful for Dr. Kaplan for taking me for 1 year, he told me, but that 1 year went for almost 40 years. One of the things that has happened in my own lifetime and in your own lifetime is the definition of hypertension. I entered the field as a student of hypertension when the diastolic was 105, according to JNC1. I do want to mention one, Dr. Manchanda, Dr. Pandya, and Dr. Nambiar. The chairman of JNC1 was a person of Indian origin, Dr. Iqbal Kishan from Kashmir. He was a chairman of JNC1, and please keep that in mind that he was the first chairman. And actually, I reviewed the document as a young resident at that time. Since then, the definition of hypertension has changed quite a bit in our own lifetime. Now the new definition is 130 by 80, and there is nothing wrong with it because of the new evidence. So one thing that I have noted in my own career, which you did, is the definition of hypertension has been steadily downgraded because of accumulating evidence. So I wrote this editorial in 1983, should mild hypertension be treated? And this was an invited editorial. At that time, I concluded that probably the ideal blood pressure for us should be 130 by 80. This is what I thought in 1983. That is the blood pressure that the community should have in general, with few exceptions. And after so many years, looks like now that is the new norm. And this is a slide showing that any blood pressure less than 130 is likely to be beneficial, systolic, and any blood pressure that is greater than 130 has no benefit at all. So ladies and gentlemen, the greatest benefit is accrued when you lower the blood pressure to less than 130, and there's no advantage at all of having the blood pressure greater than 130. So these are the 2 definitions of hypertension, the 2 different societies, but see, the goal blood pressure is the same. So you don't have to worry which classification you want to follow, which guidelines you want to follow. Don't worry about it at all. Don't lose your sleep about it, because the goal blood pressure, however it is, should be 130 over 80. You will notice on this slide that majority of complications occur in people whose blood pressure is less than 140 by 90. I'm not talking about 200 by 120. Vast majority of cardiovascular complications occur in people blood pressure less than 140 or 90. They are between 130 to 140, between 80 to 90, and that is the reason why we want to treat blood pressure to 130 by 80. So ladies and gentlemen, the definition of hypertension, despite initial controversy, has changed, and it is 130 by 80. Now question is, how do we apply it in our own country, namely India? This is a study that I'm going to show, Mr. Chairman, not published yet. If some of you are taking photographs, so please keep it for yourself, not for dissemination, because the manuscript is under preparation. So this is a study that we have undertaken to see if we can reach the new goal blood pressure of 130/80 in Indian patients using combination therapy, and whether this can be confirmed by 24-hour ambulatory blood pressure and by central aortic blood pressure. This is, in my opinion, the first study to be done worldwide, applying the new goals of blood pressure to confirm it by 24-hour blood pressure and by central arterial blood pressure. So this is a study, results preliminary baseline study, and you will notice the combination of telmisartan plus amlodipine or telmisartan plus cilnidipine. The reason why we chose cilnidipine as a comparator is more and more people appear to be using it. You will notice the combination of ARB plus CCB in Indian population, within 4 to 8 weeks, you can achieve normal blood pressure. And this is on central aortic blood pressure, once again, combination of ARB plus CCB in Indian patients has been shown to reduce central aortic blood pressure. And this is 24-hour blood pressure response. And you will notice in the combination of ARB plus CCB, the blood pressure has become completely normal. So ladies and gentlemen, in the Indian setting, we were able to demonstrate that using the new goals of blood pressure and combination therapy, one can achieve the goal levels of blood pressure among our patients. So the latest guidelines for hypertension, I wrote this editorial, one should adopt and adapt, and looks like we have adopted, and based on this study, I can say that we have adapted also. Recent guidelines for hypertension are actually directed more towards India, I feel, because every guideline mentions Indians are at high risk. And this is the editorial that I have written, that it is a clarion call for blood pressure control in India, because all guidelines have a subsection among Indians who are at high risk. So the reason why we are at high risk, ladies and gentlemen, is hypertension in India is the leading cause of cardiovascular and cerebrovascular disease. So that is about the definition of hypertension, how it has changed during our own lifetime, and how we can apply it to the advantage of our patients. Now I'm going to talk about the evaluation of patients with hypertension. Primary hyperaldosteronism is not that common, but ladies and gentlemen, it is not that uncommon either. If the patient has unexplained hypokalemia in the absence of a diuretic and hypertension, please think about primary hyperaldosteronism. It's not that rare, although it is not that common, but think about it. Let me show you the very first patient I have seen when I was a resident. This was a patient, even after 40 years, I remember the name of the patient, Mr. Betancourt. He used to come to the emergency room with repeated attacks of ventricular fibrillation, and he was found to have hypokalemia. I thought because of hypokalemia in the absence of diuretic, he may have primary hyperaldosteronism, and I was a resident. And then we made the diagnosis of primary hyperaldosteronism. He had adrenal adenoma, which was removed. Hypokalemia got better, and then the attacks of ventricular tachycardia, ventricular fibrillation disappeared. So ladies and gentlemen, unexplained hypokalemia in a patient with hypertension, think about primary hyperaldosteronism. And this is a more recent patient of mine from Apollo. Look at the sodium, look at the potassium, look at the aldosterone, look at the plasma renin activity. This is classical primary hyperaldosteronism. The patient had adrenal tumor, which was removed, and the patient got better. In the red color is the patient's blood pressure on multiple medications, but the potassium was 2.4 all the time. And we diagnosed primary hyperaldosteronism, adrenal gland was removed, and the blood pressure was 110/70 on no medicines, and the potassium has become 4.4. Some clinical clue about primary hyperaldosteronism. Pheochromocytoma, like primary hyperaldosteronism, is not that common, but not that uncommon either. The usual features of pheochromocytoma are known to you, but I'm going to show you one case that I saw had unusual features of pheochromocytoma. This was a lady who was admitted to a major hospital for fever of unknown origin. And during workup, they noted the patient had an adrenal tumor. And then they asked the patient, if she had any symptoms. And the patient said that she had occasional palpitations and sweating, and she did not know why she was having palpitations and sweating. So I suggested that the patient should undergo workup for pheochromocytoma. And then the patient, in fact, turned out to have pheochromocytoma. It was removed and the patient got better. A patient, by the way, is still alive. She's a former first lady, wife of a former president. She's still alive after removal of pheochromocytoma. Now, renovascular hypertension is an important entity that I wrote about. In patients who have atherosclerotic renal artery stenosis, even if you do angioplasty or aortorenal bypass, you will never achieve cure. But in patients who have fibromuscular dysplasia, if you do proper angioplasty and stent, Dr. Mantosh Pandya is an expert on renal artery stenosis, fibromuscular dysplasia. And this is a patient that I saw at Apollo who had multiple medications for a long time, and she turned out to have fibromuscular dysplasia. So I asked I think it was Dr. P.C. Russ, I asked him to do angioplasty on both sides, and the patient underwent angioplasty. Stent is not needed, by the way, for fibromuscular dysplasia. Look at the patient's blood pressure, 132/84 on no medicine, zero medicines. Whereas on multiple medications, his blood pressure of 190 or 116. So the moral is, in patients who have non-atherosclerotic renal artery stenosis, you can offer cure by appropriate treatment. Now I'm going to talk for a few minutes on my experience with antihypertensive drugs. I talked about definition of hypertension. I talked about some selected cases of secondary hypertension. Fortunately, I had privilege of working with many of these drugs that are shown on this slide, and I'll show you some examples. Ladies and gentlemen, and Mr. Chairman, this is my very first paper that I have written in my life, article number 1 in my bibliography in Lancet. I was a second-year resident. I was surprised that it was accepted. I talked about glucose intolerance and diuretics, and subsequently it was confirmed. The question was, when you give a diuretic and the patient develops hypokalemia, is the hypokalemia worse when the patient is eating high salt diet? If you reduce the salt, does hypokalemia get better? Because the more salt you take, the more potassium is lost. And this is a study that we did in Dallas along with Dr. Kaplan. We showed that hypokalemia gets worked when the patient is on a high sodium diet. But when you ask the patient to restrict the sodium, the potassium losses are minimized because sodium is exchanged for potassium. So this is the first study to demonstrate that diuretic-induced hypokalemia can be attenuated by putting the patient on a low-salt diet because sodium is not available to exchange with potassium. Now you noticed in all the last 3 guidelines, chlorthalidone has had received special mention. And we looked at chlorthalidone many years ago when I was in Dallas. We did a study comparing hydrochlorothiazide to chlorthalidone. And in that study, we noted that chlorthalidone was slightly superior to hydrochlorothiazide in reducing the blood pressure. And now all the 3 guidelines do suggest chlorthalidone as a preferred drug, preferred diuretic in the treatment of hypertension. Now the question would be, supposing somebody develops hypokalemia from a diuretic, how can you increase it without giving potassium supplements? This is a study that I did many years ago. We made the patient hypokalemic on a diuretic and we gave them amyloid. When we gave them amyloid, then the diuretic-induced hypokalemia became normal. So this was the first study to demonstrate that when you give amyloid in patients with diuretic-induced hypokalemia, the potassium improves, and it confirmed its potassium-sparing abilities. Now, the beta blocker controversy. Beta blockers have been controversial, but I don't think they're that much controversial as people say. And this is something that I have written on the effects of beta blockers long time back. You know, although we don't see it in India, in US, there was a belief that black patients don't respond to beta blockers, and they thought they don't absorb beta blockers. That is not true. This is a study that I did in African-American black patients with hypertension. We gave them beta blockers. Beta blockers lowered the heart rate, but did not lower the blood pressure. So we concluded they in fact absorb beta blockers, as demonstrated by bradycardia, but the antihypertensive response is not there. So we showed they are beta blocked, but the blood pressure doesn't come down in black patients. So beta blockers, they are truths and half-truths, and all the controversy is due to atenolol. You will notice with non-atenolol beta blockers, as shown on this slide, you can actually provide primary prevention, secondary prevention, and heart failure. And that is the reason I wrote that editorial, beta blockers, truths and half-truths, because many beta blockers, other than atenolol, appear to provide significant cardiovascular protection. Now, ladies and gentlemen, calcium blocking drugs are widely used in the treatment of hypertension. And there was some theory a few years ago that they're more effective in older patients compared to younger patients, just like opposite of beta blockers. Whereas I thought calcium blocking drugs are equal in all age groups, and this is what I have written in a major journal. Subsequently, it was shown that whether you're young or old, calcium blocking drugs are equally effective in the treatment of hypertension. So what I had written, that calcium blocking drugs are equal in all age groups, is now what we accept at the present time. The question is, what will happen to atherosclerosis when you give antihypertensive drugs? Does hypertension cause atherosclerosis? Does the treatment of hypertension decrease atherosclerosis? And all of you know the classical coarctation of the aorta. Above the coarctation, there is atherosclerosis. Below the coarctation, there is no atherosclerosis, suggesting that it's the intramural blood pressure that causes atherosclerosis. This is a study that was done with calcium blocking drugs using amlodipine as a calcium blocking drug. And they noted when amlodipine was given as a calcium blocking drug, there was a decrease in atheroma volume, suggesting anti-atherosclerotic effects. So what I thought that anti-atherosclerotic effects could occur with antihypertensive drugs was shown in this study called Camelot, where calcium blocking drug has been shown to decrease atheroma volume and event rate and does have anti-atherosclerotic effects. Now, let me tell you, in a lot of instances, I have been wrong also. And that is how science is. You say something and you could be wrong. This is when captopril was introduced in 1982. I wrote this editorial on the uses of captopril, and believe it or not, this is what I wrote in that editorial, that ACE inhibitors are contraindicated in patients with proteinuria. Totally wrong, absolutely wrong. Subsequently, it was shown not only they are not contraindicated, but they're indicated in the patients who have proteinuric disorders. So that's how it happens with when you write something. So ACE inhibitors now are useful in proteinuric disorders. What I have written was absolutely 100% wrong at that time. Now I want to mention a few things about Archamine, which is an older antihypertensive drug. And then there was a belief that when you stop clonidine or Archamine, there is so-called blood pressure overshoot. Blood pressure overshoots when you stop clonidine. I thought that blood pressure cannot overshoot. It may go back to the baseline, but cannot go above the baseline. And this is a study that we did where we showed with clonidine, the blood pressure would come down. When you stop clonidine, the blood pressure goes to the baseline. So there was no overshoot. It just goes back to baseline like any other antihypertensive drug. So there is no withdrawal phenomenon. It is return to hypertension after you stop antihypertensive drug therapy. Now the question is ambulatory blood pressure monitoring, because every time we take the blood pressure, it changes minute to minute, nurse to nurse, outpatient to inpatient, etc. The question is, should we use ambulatory blood pressure monitoring in clinical practice? And this is a study, probably the first study ever to be done by me and Dr. Kaplan, looking at blood pressure control during once-a-day administration of antihypertensive drugs. And we noted that when we did the ABPM, the blood pressure was well controlled for 24-hour period with long-acting antihypertensive drugs. But I would not recommend ABPM with cuff anymore. One should try to use ABPM without the cuff, because using the cuff is very inconvenient. So this is a study, this is my 24th article in 1980, showing that you can control hypertension for 24 hours as long as you give long-acting antihypertensive drugs. And subsequently, people have demonstrated dipping, non-dipping pattern, etc. Now, What happens to the blood flow to the brain in elderly patients when you treat hypertension? Remember, Mr. Chairman, ladies and gentlemen, the fear that all of us had is when you treat hypertension in the elderly, we drop the cerebral blood flow. And we were afraid that we might actually decrease the cerebral perfusion. And therefore, we wanted to do this in clinical research. We wanted to measure the cerebral blood flow with a new technique. And we actually measured the cerebral blood flow in the elderly patients after the treatment of hypertension. You will notice on this slide, when we gave antihypertensive drugs to the elderly, the blood pressure came down, but you look at the cerebral blood flow, there was no reduction at all. So we concluded that despite the fall in blood pressure, you can maintain the cerebral blood flow because it is auto-regulated. It is auto-regulated. So this is a study assuring you and me that when you lower the blood pressure in the elderly gradually, there's no reduction in cerebral blood flow as demonstrated by us many, many years ago. Now, regression of left ventricular hypertrophy. All the prominent cardiologists are in the panel. I see them. Left ventricular hypertrophy, of course, is very common in patients with hypertension. A lot of people have it. How quickly can you cause regression of left ventricular hypertrophy when you treat hypertension? So this is a study that we did in 1987-88, published in 89. We noted using a very new technique of cardiac imaging at that time that within 4 months, you can cause significant regression of left ventricular hypertrophy. So we concluded that when you treat hypertension aggressively, you will start seeing regression within 1 month, but at 4 months, you have significant regression of left ventricular hypertrophy as a result of good blood pressure control, very nicely demonstrated at that time with a myocardial scintigraphy, very nicely done at that time. Now, I want to mention, I'm almost coming to the conclusion, about an alpha blocking drug, prazosin, which some of you might still be using. I know there was some controversy when prazosin was released, whether this is an alpha blocker or a RAS blocker. There was some controversy. So we did the study where we give non-epinephrine infusion at the baseline and after the patients were treated with prazosin. You will notice when non-epinephrine was infused in patients receiving prazosin, there was no increase in blood pressure. Whereas when we infused angiotensin, the blood pressure went up. And our conclusion was, and that reference is there, that prazosin is an alpha blocker because it prevented the blood pressure rise in response to non-epinephrine and not a RAS blocker. I think this is the first paper to demonstrate that prazosin is a classical alpha blocker because the non-epinephrine increased blood pressure was prevented in the presence of prazosin. So lastly, now we have come to so-called triple drug combination therapy, which I would strongly advocate for patients who require it. And this is the last study that I did before coming to India and US, using triple drug therapy for hypertension in patients who have diabetes and hypertension. You will notice when we gave a CCB, ARB in a diuretic, there was a significant drop in office and ambulatory blood pressure monitoring, demonstrating that triple drug therapy in selected appropriate patients is quite effective in reducing the blood pressure and there's no danger of hypotension. Then stroke in India is very common, and this is a paper right now in press from our institution. We looked at 530 patients came to the stroke unit with acute stroke. And we analyzed the risk factor for stroke. It was hypertension followed by diabetes. All this, you know, all of this. But at least we were able to confirm that in India, a prospective study has demonstrated it is because of hypertension, patients come with acute stroke followed by diabetes. And lastly, ladies and gentlemen, my journey has taken to the culmination of the invitation that I got from the Cardiological Society of India to produce a book on behalf of the Hypertension Council. The council members of Dr. Iyengar, Dr. Nair, Raini Nair, Dr. Wander, and Dr. Srinivas Kumar. And Dr. M.K. Das has given me this challenge at a short notice to produce a book on hypertension reviews, Cardiological Society of India, and we were able to do it in a short time. Thank you for the privilege and opportunity. And I'm told that it is being released at this conference. Now, I have given you, Mr. Chairman, ladies and gentlemen, a glimpse of the experiences that I had and the privileges that I had and the fortune I had. Diagnosis of hypertension, evaluation of hypertension, 24-hour blood pressure control, and evaluation of antihypertensive drugs in clinical practice. So if I can share one slide, I wanted to thank, can you put the slides back, Anand? By any chance, just a conclusion slide. I wanted to thank Dr. M.K. Das, that was his photo, for giving me the opportunity.
Sir, please go ahead, sir.
Okay, and then I also want to thank the incoming president, Dr. Mohanan, of the scientific committee for asking me to do it. Those were the two slides. One slide was of Dr. M.K. Das, and other was of Dr. Mohanan. I thank them. I wish them all the best. Mr. Chairman and ladies and gentlemen, in the time that was allocated to me, I gave you some selection of the diagnosis, evaluation, management of hypertension that I had the privilege of working with. And I hope that I will continue this journey to do what is right for the patient at the right time, which is right for the community. Thank you very much.
Thank you, sir, Dr. Ram. In fact, just before the chairperson's takeover again, it's a privilege from Cardiological Society of India that we are offering you the medallion of BC Rai Oration and Award. Actually, since this is a hybrid session, so it's being shown virtually. And Dr. Mohanan, please. And the scroll being shown by Dr. P.P. Mohanan, who is the incoming president. Thank you, sir. You are really great, and really we are honored to bestow this oration upon you. Thank you, sir.
Thank you.
Over to Chairperson, sir. We are running short of time.
Shokan, please.
Friends, you all agree with me and our co-chairman that it's a fantastic oration doing full justice to the person in whose name the oration is named, Professor B.C. Roy. Now, Professor Ram has dedicated his life for hypertension, and we are having the proofs of that dedicated life by plenty of high-quality studies. And now we have confirmation of the effect of all the current hypertensive agents and how lowering blood pressure improves lives, reduces complications, and will have better quality of life. Thank you very much, Professor Ram, and we have great pleasure in endowing this award as mentioned.
Thank you, Chairperson, sir. And it's again a privilege that one of our very esteemed past presidents, Dr. H.K. Chopra, has actually written this book, Hypertension New Frontiers. So it's being released today and dedicated to the members as well as all the people who have joined this conference. Thank you.
Is Dr. Diman ready?
Dr. Diman ready? Can you go live with Dr. Diman?
Dear friends, as we earlier mentioned, we're going to see the National Interventional Council data presentation today by the convener of the Interventional Council, Dr. Diban Kahali. We've been getting these data every year, during the NIC meeting, and because of the challenging pandemic, we have to postpone it. That's why, but then these are important data. These are data about how our country is using these various devices, various procedures, which makes a lot of difference. And that practice pattern is something which will be useful to every member of the Cardiological Society. If Dr. Diman is ready, over to you, Dr. Diman.
Sir, you can talk, sir. You can start, sir.
Yeah.
You are ready.
Yeah. Respected Chairman, respected ladies and gentlemen, I am going to present the NIC registry data for January to December 2019. Now, first I show the incidence of MI in India between January to December 2019, and it is estimated around 33 lakhs. And 41% of the patients were thrombolized, and primary PCI was done in only 2.3% of the patients. What is very disastrous is that rest of the patient, that is 57% of the patients, were not reperfused either by thrombolysis or by primary PCI. And this data is almost similar to the data in 2017, where primary PCI was done in 1.56% of the patients and 40% of the patients were thrombolyzed. So we have to improve our awareness program so that majority of the patient gets the benefit of reperfusion, either thrombolysis or angioplasty or pharmacoinvasive. The first center to submit data, Apollo Ridge Hospital, Karimnagar, thanks a lot. And the most complete data came from Sri Jayadeva Institute of Cardiovascular Sciences, Bengaluru, under the leadership of Dr. Manjunath. So congratulations. And these are the 5 centers which are the topmost in India. They have presented the data. Sri Jayadeva Institute of Cardiovascular Sciences and Research from Bengaluru, G.V. Pant Institute of Medical Sciences and Research from Delhi, Meditrina Hospital, Kollam, King George Medical University, Lucknow, and UN Mehta Institute of Cardiology, Ahmedabad. And state-wise, this is the market share which we could gather. Karnataka 11.52%, Maharashtra 10.73%, Kerala 9.42%, Tamil Nadu 9.34%, Gujarat 9.16%, Telangana 7.68%, New Delhi 6.94%, Uttar Pradesh 6.36%, Rajasthan 6.09%, Andhra Pradesh 4.72%, Haryana 3.69%, and West Bengal 3.56%, Punjab 2.49%, Madhya Pradesh 1.79%, Odisha 1.35%, and the rest of the states have contributed each less than 1%. So I am just showing the names, not mentioning the figures. And these are the centers of best centers performing. Andhra Pradesh Ramesh Cardiac Center, Vijayawada, Assam GNRC Heart Institute, Bihar Indira Gandhi Institute of Medical Sciences, Chandigarh PGI MER, Chhattisgarh Apollo Hospital, Bilaspur, New Delhi, GB Pant Institute of Medical Sciences and Research, Delhi, Goa Medical College and Hospital, Panaji, Gujarat, Even Mehta Institute of Cardiology and Research Center, Ahmedabad again, Haryana, Medanto, the Medicity, Gurgaon, Himachal Pradesh, it's in Shimla, Jammu and Kashmir, SK Institute of Medical Sciences, Srinagar, Jharkhand, Tata Main Hospital, Jamshedpur, and Karnataka Sri Jayadeva Institute of Medical Sciences, Bangalore. And Kerala Medicina Hospital again in Kollam, Madhya Pradesh, Rajeshri Hospital, Indore, Maharashtra Ruby Hall Clinic, Pune, Manipur Sky Hospital and Research Center, Imphal, Meghalaya, Nerim, Shillong, Orissa, Apollo Hospital, Bhubaneswar, Pondicherry, Jipmar, Punjab Capital Hospital, Jalandhar, Rajasthan, SMS Medical College, Jaipur, Tamil Nadu, Meenakshi Hospital and Madurai, Telangana, this is from Secunderabad, Uttar Pradesh, King George Medical University, Lucknow, Uttarakhand, Sri Mahant Indres Hospital, Dehradun, and West Bengal, BM Birla Heart Research Center, Kolkata. And this is the total amount of interventions done. You can see the graph. There was a increase all along from 2017 to 2019. It was 3,87,416 in 2017, which increased to 4,93,684 in 2019. And this we can see that in 2017, almost 5% of the centers were doing less than 200 procedures per year, but in 2019, the numbers have come down to only 4%. That means all the centers are doing more of procedures. 201 to 500 procedures were done in 16.56%, 501 to 1000 procedures were done in 23.27% of the institutes, 1000 to 2000 in 24.91, that means in quarter of the institutes, and more than 2001 in 31.24%. There is a steep jump from 20.12%, so almost 50% jump from 2017. So that's very good. And coronary intervention data for the year 2019 center and PCI volume share. This is a pictorial demography which I showed just now, and you can see that more and more centers are doing more than 2000 procedures now. And this is the age-wise, below 40 years, 12.5% of the patients are below 40 years, and 15.8% of the patients are more than 70 years. And this is almost consistent from 2017 to 2019. This is gender-wise, male patients, the incidence has increased very little from 69.63% in 2017 to 2019, 70.57%, and the incidence in ladies has decreased a little from 30.37% to 29.43% in 2019. And this is very interesting data that in 2017, from oneself, it has been done in 39.39%, and in 2019, it is only 30.35%. That means patients have gone some sort of remuneration, I mean the settlement from either government or insurance. But again, if we see that the government ownership was 43.68% in 2017, and it is 55.15% in 2019. So the government, like Ayushman in our West Bengal, there is Shastro Shati, Shishu Shati, etc. So the government help has increased a lot, and even the private hospitals are taking the benefits, and there is a steep increase in the number from 43% to 55% within 2 years. And private insurance, the incidence has again come down. We are not insurance minded in our country like USA or other Western countries, so we have to motivate our patients so they don't have to spend from their own pocket. And private insurance was 17% in 2017, and that has come down to 14.5% in 2019. And these are the indications for PCI, that if we look at it, primary PCI contributed to 18% of the cases, post MI 28.57%, and rescue PCI 5.45%. So if we make a sum of all these, MI related procedure were more than 50%, it comes to 52%. Unstable angina 23.56%, and cardiogenic shock patient 3.16% were cardiogenic shock patient. And in chronic stable angina also procedures were done, and that constitutes 18.51% of the procedures, and before non-cardiac procedure the incidence of PCI was 2%. Single vessel disease contributed to 72% against 80% in 2017, multi-vessel disease 27.29% as opposed to 19.76% in 2017, and left main contributed to 2.67%. So this is like US rather, not like the West European countries where a lot of left main interventions are done. So we are more and more dependent on our surgeons for the left main angioplasty. But graft angioplasty, there was 300% increase from 1.11% in 2017 and 1.01% in 2018 to 3.11%. So there was a steep increase in graft angioplasty this year. LAD 2017 47%, and same 46.18% in 2019. RCA was done same 27.48% against 29.04 and 29.16 in 2017 and 2018 respectively. Circumflex lesions were done in 19% of the patient, almost same as previous years. Left main intervention 2.67%, and graft angioplasty in 3.11%. Bifurcation PCI incidence was 5.33% against 4.55% in 2017. I should tell that the bifurcation PCI is also little less, because if we compare the EBC data and the American Bifurcation Society data, we find approximately in 15% of the patient they do bifurcation PCI. So it's little less in our country. And CTO is done worldwide in approximately 10% of the patient. In our country, it has increased from 3.61% to 5.63%, and instant restenosis PCI was done in 2.38%. It's a little more than 1.66% in 2018. And retrograde PCI was practiced in 0.3% of the patient against 0.29% in previous 2 years. So it has doubled, and numerically also. And you know, the retrograde PCI, many of the young operators as well as expert operators are performing this procedure increasingly, and the results are also very good. And Japanese performers also come, interventionists from Japan, and there are many workshops in the country which has occurred for retrograde PCI. So these are very encouraging data. POVA only was done in 3.18% of the patient. Any GP2B3A use in 20% of the patient. Increasingly, GP2B3A use is coming down all over the world, but in our country, it's still 1 in 5 patients is getting GP2B3A inhibitors. Bivalirudin use is very less, 0.58%. It has shrunken further from 0.89% in 2018, and vessel closure devices like angiosil in 1.52% against 2.33% in 2017, and it's almost same as 2018. Now, these are the numbers of total primary PCI. As I mentioned, it was 1.56% in 2017, 553,416 patients got the benefit of primary PCI out of 30 lakhs MI patients in that year, 2017. This year, it has increased to 76,287. It's among the procedures, it's constituting 15.45%. But the incidence of primary PCI in MI patients, which constituted total 33 lakhs patient, it is 76,287%, constituting 2.3% of all the MI. So very mega result. We hope that we should be increasing primary procedures and pharmacoinvasive procedures more during the coming years. Total stents used was 5,11,389, and in 2019 it has increased to 6,31,915. And the DES use is also increasing consistently, and in 2019 99.23% stents were DES as per the global trend. This is a very interesting slide, that is the coronary stents market share. Abbott Vascular almost same, little improved in comparison to 2018, 30.08%. Medtronic's 10.09% against 9.33% previous year. Boston Scientific almost same, 6.96% against 7.01%. Biotronic 2.49% against 3.98% previous year. Terumo also almost same. So total MNCs contributed 50.62% against 51.19% in 2019. And the total percentage contributed by the indigenous companies, that is Indian companies, is 49.38. So I think our Honorable Prime Minister, Mr. Narendra Modi ji, will be very happy to get this data, because it's almost a 50-50 situation now. And there has been little alteration in comparison to the previous year, what was 51.19 for the MNCs and 48.81 for the indigenous stents. So this is a encouraging data that more and more indigenous stents are gaining ground, and our young entrepreneurs, the interventional cardiologists, as also the experienced expert leaders are also relying more on indigenous technology. SMT share has increased a little to 15.2%. Merrill is almost same, 10.63%. Translumida 9.8%, vascular concept 3%, and these are 2% and others 4%, that makes 49.38%. So Modiji's vision of made in India and make in India is becoming increasingly true, and we congratulate him for capping the price capping 3 years back. And this is the incidence of other devices used. Rotablation has been done in 1% of the patient. Worldwide, rotablation is done in 10% of the total procedures. It is little less in our country. And OCT, there is another technology which has come for the last 2 years in our country, that is Ivl Intravascular Lithotripsy, but it is very expensive, but is slowly gaining ground. And imaging has been done in the form of OCT or IVUS in 5% of the patient in comparison to 4.22% last year, that is in 2018. FFR was done in 1.9% of the patients, and the use of physiology is also not increasing in a manner what it should be, maybe because of the financial restraints which all of us face. But numerically, if we see, it has almost doubled from 5,296 to 9,500 in 2019 from 2017. Death was low. It was 1.12% in 2017. It has increased a little to 1.51% in 2019. And in primary PCI, the death rate is consistently same, 2.6% in 2019. Emergency CABG was required in 0.67% of the patient, a little increase. In hospital Q-wave MI is in 1.52%, maybe because of increasing use of TROP-I and other biomarkers, sensitive biomarkers. Acute renal failure, 1.35% of the patient, and major bleeding in only 0.31% of the patient because of increasing vascular access site of radial by young and also expert cardiologists. Renal angioplasty was done in 2,119 patients because the latest trials show, like Coral, that the threshold of renal angioplasty has gone up, and in very serious circumstances, we resort to renal angioplasty. Carotid was done in 2,232. There has been some increase, almost 25% increase in carotid procedures. Peripheral was little less, 9280 in comparison to 2017, and the total procedures was 13,631, up from 2018 data, but little less than 2017. And this is the valid data of structural intervention. PTMC in 2017 was 8860. In 2019, it is 8731, almost same. TAVR was done in 70 patients in 2017. Only Medtronic was there at that time. In 2018, it is 350, and it has almost doubled in 2019. it's 611. So TAVR is slowly gaining ground, but again the same story, it's so expensive and prohibitive in our country. Pulmonary valve balloon dilatation in 1237 patients, aortic valve balloon dilatation in 777 patients, tricuspid valve dilatation in 115 patients. So the total number of structural valvular procedures this year in 2019 was 11,500, almost little up from 10,893 in 2017. And this is the distribution of the market share. In TAVR, in 2017, only Medtronic was the only player, 70 cases done. In 2018, there were 3 players, and Medtronic did 180, and Merrill 110, and Edwards 60, making 350. And this year, means 2019, 280 by Medtronic, Merrill 251, and Edwards 80, the data which we could gather from different institutes. This is the other structural interventions, PDA device closure, 4132, little up from the previous year, 3301. ASD device closure, 4866, and this year it was 6339. VSD device closure, 1240 in 2018, it has come up a little, 1444. Post MI VSD closure, 84. So these are very challenging procedures with a very high mortality. Whatever way we go, surgery, medical treatment, or intervention, the incidence of mortality is very high, and but still 84 cases were done in the country. So the total interventions were 12,000 in 2019. Balloon aortic septostomy, these are the neonatal interventions. 2017, 163, it's almost same, 171. Last year, it was little more. Aortic valve balloon dilatation, 164 cases. Pulmonary valve balloon dilatation, 207 cases. Coarctation of aorta dilatation, 193 cases, little down from the previous years. Pulmonary valve perforations, it was done in 44 cases, little more. PDA stenting in 239 patients in neonates. ASD closure with this is in 2019, almost 5,000 cases, little up from the previous years. VSD muscular 769, VSD perimembranous 956, little up from the previous years. VSD residual 296, much better than 2018 data, and PDA 3422 from 3392 in 2017. Rupture sinus of Valsalva, it is 666, much better than the previous year, almost 4 times than the previous years. Aortopulmonary window 19, same. Paravalvular leak was repaired in 40 cases. BT shunt in 8 cases, and large collaterals 173. And these are balloon therapies, aortic valve balloon dilatation in 607 patients, PVBD in 738 patients, PV perforation 56, PTMC 1158, coarctation dilatation 237, renal angioplasty in children 47, coronary intervention in children 63 cases, obstructed TAPVC intervention 7, and BAS in infants and older children 36. And this is the EP data, and single chamber pacemaker was implanted in 1,47,048 patients, dual chamber pacemaker in 13,600 patients, and the incidence of pacemaker was more in the eastern India because reasons not fully known to us. CRTP in 960 patients, and CRT-D in 1,432 patients. Epicardial pacemaker 208 patients, epicardial LV lead implantation in cases of CRT in 120 cases, and lead extraction done in 295 cases. Now, these are the challenges. No data available at root level. Only 5% cath labs have system to maintain data on daily basis. Lack of long-term policy by us in NIC registry effective and successful. But we are trying to have a CSI web portal where I would request all the interventional cardiologists from all over the country, and especially I would request our senior mentors and expert interventional cardiologists to log in the CSI web portal all the cases on a daily basis, which is possible now, and that will change the picture. And the next challenge is responsibility ownership issue in cath labs due to changes in HOD and multiple operators. But that will be happening. That is a normal phenomenon, and that will be going on happening. Digital, and what are the suggestions? Digital is the answer. This pandemic has made us efficient in virtual connection. This meeting also, we are having hybrid and more of virtual participation with 23,000 plus attendees in this CSI conference, Ahmedabad. We should initiate digital ways of collection of data, as I mentioned, and integrate the system in the cath lab so it becomes part of the daily routine. To bridge the skill gap by digital technology, partner with international centers of repute for trainings of fellows, young cardiologists, and improve data accuracy. This could help in analysis and showing many good research work from India and help in improving patient outcome. So unless we have got some more data, and data accuracy is very important, and we were going from door to door asking for the data from different labs, and I thanks all the interventional cardiologists for their kind help, favor, and kind contribution in data collection. I also thanks the technicians from different labs for helping us a lot, and I especially thank Mr. Sakir Singhi and his JVS group for helping us to collect the NIC data in a successful way. And I would ask and request all of you to give us suggestions for better functioning of collection of this NIC data. And again, I would request to put all the data in the CSI website portal from 2021 January, and that will give us a more accurate data collection so that we can have more of Indian papers and more of data collection and more of research work. And last of all, I thank you all for your kind attention, and especially with a lot of respect and gratitude to all the panelists and chairperson sitting on the dais, and to all the ladies and gentlemen.
Thank you, Dr.
Very,
Diman, for that very fascinating data of the NIC of 2019. As you rightly said, what is possibly more interesting to see the changing market dynamics, the pre-NPPP and the post-NPPP. And if you look at that, it is one of the real deficiencies of our NIC registry. Every time we lament was the improper the system of the interventions, and you are right that we should be doing better things in gathering the data, because if you look at the Times of India, the manufacturers' data on the stent number, you could see that this is about 6.5 lakhs. So the market proportions of the various providers may be a little different. What is possibly, as you rightly said, most important change has been after the capping, the dominance or the increasing presence of the Indian companies, which is possibly, as you said, a welcome change. So thank you very much. Before we conclude, I'll get a comment from Professor Banerjee, and then we'll conclude.
Thank you, Dr. Kahali, for giving a nice disposition of the NIC registry data. And as you have seen from your slides, that there is a greater performance of the Indian companies as regards the stent is concerned, as well as the tower. But I'd like to get your opinion about one thing. Why not the pacemaker companies are also coming up from the Indian origin to have a more comparable type of devices as like global, so that the prices can come down and we can give service to the more needy people. What is your comment on that?
Hope, Dr. Banerjee, that more and more Indian companies will be coming in this era also. We have the best of technologists, we have the best of engineers, best of scientists. In NASA, 25% of the scientists are from India. So there is no dearth of good brains in India, but probably this is a more intricate and more complex technology and more of investment. So I think it will take a few years time, because at present the stent technology has improved a lot, and the data shows, because we are getting more and more confidence in our Indian stents, we are putting them, and personally also we haven't got much of problem, and there is no adverse reaction, and it is definitely non-inferior to the Western multinational stents. So that is possible because of our Honorable Prime Minister. After the price capping, things have totally changed, and there has been already registries going on, like the Tuxedo 1 registry, where we found that the Indian stent is non-inferior to Giants, which is the benchmark stent, and now we are having Tuxedo 2 trial, where also we are
Dr. Kali, you are running short of time. Please conclude.
Benchmark, yeah.
Thank you very much, Dr. Kali. We conclude this session. Thank you very much.
Thank you very much. Thanks. Good evening.
Anand. Ladies and gentlemen, now we have the most auspicious part of the CSI 2020 meeting, the presidential oration by our President Mrinal Kanti Das. And to initiate the oration part, may I request Professor Khalilullah to start these proceedings. Sir, over to you.
Hello, am I audible?
Yes, sir. Yes, sir.
Yes. Thank you for inviting me to chair the most important session, that is presidential oration. Dr. Mrinal Kanti Das is a very accomplished cardiologist who has taken the CSI through the most turbulent time in the history of CSI. First of all came the lockout, then came the COVID, then came the hybrid and virtual conference of the CSI. Handling all these difficult times, I must salute Dr. Mrinal Kanti Das for conducting the session and making a very useful and successful conference of the CSI in Ahmedabad. I would request him to give his oration on a very special topic we have chosen, cardiovascular disease, origin and sources. Dr. Mrinal Kanti Das, as far as I remember, I was his examiner, his DM Cardiology. These few words, ladies and gentlemen, may I present to you your President, Dr. Mrinal Kanti Das. Dr. Das, please.
Good evening, namaskar. I pay my regards to my teacher, Professor M. Khalilullah, from whom actually I have learned so many things. And I have chosen a subject today which is very close to my heart. Now, before I go to my journey, let me take you to one of the oldest botanical garden, that is Calcutta Botanical Garden, where you can see the vast historical great banyan tree. And this banyan tree's importance is that we don't know the root, and nobody can find out which is the root. And in fact, cardiovascular disease is also like a very, very big banyan tree. And what I'll try to have my journey for the search of fons et origo, or roots. Actually, I'll try to blend some of my own works where I have been involved personally, and also some of the literature reports, and thereby I'll progress with the journey. Now, just before going to that, I pay my regards to my own country, Cardiological Society of India, my parents, and also my teachers and mentors like Professor Sisikar, Professor A.K. Borua, Professor Maiti, Dr. H.K. Chopra, Dr. P.K. Dev, who have actually guided me from time to time, apart from other members who are there in the slide. You can see them. Many of them have taught me and guided me on different occasions. Now, my questions to various problems of the cardiovascular disease started way back in 1984 when I was doing my post-graduation. And it started with the basic question whether all the conduction tissue in the heart behave same way or not. So I was evaluating actually the prima mobile, which is also known as the pacemaker of the heart or sinus node. whether it has the same mechanism of action or sort of influence on the conduction defects of heart in the form of heart blocks or bundle block and all. And for that, actually, the electrophysiological studies were taken up, and very interestingly, we took up 28 patients during the course of my study, and out of them, 8 patients, that is 36% of patients had conduction defects of heart, either AV nodal block or the infranodal block in the form of LVB or right bundle branch block or combination of blocks. And for the first time, we documented with the help of the various electrophysiological tests, that is the sinoatrial conduction time and CSNRT or corrected sinus node recovery time, in a patient of heart block, combination of AV nodal block as well as the complete heart block, and we demonstrated the evidence of the sinus node dysfunction in the form of the raised values of SSCT and CSNRT. However, because of the technological advancements not being present at that time, the atrial fibrillation with complete heart block, which is a part of the sinus node dysfunction, it was not taken up. However, as we were following up later on with my own patients, and the cohort of the patients with about 540 in number in 3 different institutions, there were very interesting findings, and about 100 patients were actually followed up, out of which 10 patients developed atrial fibrillation. And very interestingly, I grouped them into 2 groups where the single chamber pacing was compared with the dual chamber pacing, and when comparing the data or observations, we found that actually the sinus node dysfunction was, or more incidence of atrial fibrillation was there with actually those patients who are having sinus node dysfunction combined with the AV nodal or infranodal blocks, as well as those patients who are having actually the single chamber pacing as compared to the dual chamber pacing, they had the more chance of developing atrial fibrillation. And as you know, the mechanism right now that we are more related with the dysynchrony between the atrium and the ventricle with the help of with the single chamber versus the dual chamber pacing. Now, again, we put a question whether actually there can be some mechanism by which we can do something better treatment by avoiding all these mechanisms or not. And for that, actually, the literature was asked, and we were also doing works on placing the electrodes in the septum versus the apical area, and there have been some improvement in the physiology of the electrophysiological condition, and we were almost elated. Possibly we found the holy grail of pacing, but actually there were a lot of debates over the things, and as you can see that the debate is still not over, because there is no definite evidence even today that septal versus apical pacing really differ very much, and there are certain other aspects in the form of dislodgement and all which are there. So from that observational study, actually the conclusion was made that sinus node dysfunction may be associated with the infranodal or AV nodal blocks, and one must take care of that by taking more help of the dual chamber pacing. So that sort of thing was there, and we also progressed with the more study in the form of the use of the DOACs or NOACs in those cases of atrial fibrillation. I am not going into the detail of it in the interest of the time. While we were studying all these things, then certain questions, more questions arose, and while doing the the docs studies, actually I was interested more with the cardiovascular disease in the form of the various origins, especially in the form of risk factors which were influencing the course and also natural history of the diseases. So there were publications with cigarette smoking, publication in the form of the influence of the various risk factors in the myocardial ischemia in young, myocardial infarction in young, and all this. And also we studied the angiographic profile in a younger group of patients with MI and found that the multiple risk factors were very much involved with the high grade or the multi-vessel disease in patients of coronary artery disease. And subsequently, CSI West Bengal branch actually carried out one very basic study in the school-going children. I was part of the study where we found that obesity as well as the hypertension are real problems even in the children. And the study has been published in the Indian Heart Journal, and thus we went ahead with other modalities like asymptomatic individuals in patients with hypertension, and various changes were also studied. So to answer the questions regarding the various risk factors, actually, we know now that the various modifiable risk factors in the form of behavioral factors as well as the biological factors are there, and they have got the influence on the development of the disease as well as the events. And there are so many factors. But out of this, the systolic blood pressure's relationship with the coronary artery disease and other cardiovascular disease were very much highly prominent. And as you can see that actually there is a correlation, linear correlation with the increase in the systolic BP and the pulse pressure vis-a-vis the coronary artery disease, the hazard ratio increases. Very interestingly, it has been demonstrated that even higher BP than 90 millimeter mercury systolic BP can cause the more increased evidence of the atherosclerotic cardiovascular disease. And this is a real problem. This hypertension is a real problem, and there is not only the relationship with the events, but also it drains the exchequer and also influences the DALYs in the form of causing the stroke, then cardiovascular deaths directly. Now we know the various facets with the help of ambulatory monitoring as well as other home BP monitoring, and we know the different terms like the ABPM, HBPM, white coat hypertension, and all this masked hypertension, BP variability. But the question again arose, why in spite of knowing so much of information, why the things are still not being controlled? Why still we are having higher incidence of cardiovascular disease? And why this influence is there in spite of our knowledge? The question again arose in the form of, are we, the doctors, convinced when the BP is 142 by 92 or 145 by 95? Possibly not. And when we are ourselves not convinced to treat that number, so how can we convince our own patients? So there is a gaps in the concept, and what is the role of 24-hour BP variability? What is the optimal BP level that actually occurs in the circadian rhythm and we should take care of? So many questions actually are there, and to fill up the gaps actually, we try to proceed with some of the concepts. I'll come to it later on, but there has been definite influence of these gaps to influence upon the what is called the uncontrolled blood pressure, and also non-adherence to the treatment, especially with the single drug therapy and all. Now this is a slide actually, what I would like to say that when, it's a slide of a dam actually. When the dam is giving water, we are not bothered about the number, how many cusecs of water is coming out. But when the flood is there, or there is breakage in the dam, Now you are very much knowledgeable about the numbers. 1 lakh cusecs, 2 lakh cusecs of water have been given. I think same way in relation to the cardiovascular disease and also the hypertension, possibly our 142/92 is not enough to convince us, not the patients. When we actually give a total value of the BP surge differentials, that becomes a huge number, maybe 10,000, 20,000 millimeter mercury, and that can actually have a very much great influence on the cardiovascular system, and that has been actually proposed as a novel concept, and this concept is to be taken up by all of you, so that actually we can convince ourselves and others. And this is a very simple equation, and is sigma value means the summation of the BP surge differentials. And what is the implication? The implication is that the continuous bombardment of this high BP level throughout 24 hours, throughout 30 days, throughout 365 days, actually they are triggering the various systems in our body, triggering the genetic mechanisms, transduction, transcription and all, and influencing the blood vessels as well as the target organs, and thereby actually causing the target organ damage as well as the various events related to the vasculopathy as well as the target organ damage. So again, to question the modalities of these mechanisms of the hypertension and other cardiovascular risk factors influencing the whole vascular system. One article has been actually just published a few days back. This was written by me, that it is basically dependent on the vessels. There are so many theories, as you know, that the angiotensin, renin-angiotensin system, then this eicosanoids system, they are all responsible for the loss of balance between the vasoconstriction versus the vasodilatation, and they are all mediated by nitric oxides and so many other molecules. And a new concept has again evolved, that is the GLP-1 receptor agonist, which can actually influence so many mechanisms in the form of the various risk factors like obesity, then hypertension, the vasculopathy, and all these can be taken care of by the GLP-1 the receptor agonist. So there is no unifying theory as such. It's a polymorphic thing, like the roots of the banyan tree of the vascular banyan tree in the botanical garden. So to circumvent that, actually, there have been proposals for the combination of therapies, and these are being tried, even now extrapolated to the combination of the various drugs like statins, aspirin, and other drugs, along with the antihypertensive, with low doses of the combination, and they have actually salutary effect. Many trials, many tests have been carried out in India, Sri Lanka, and other countries, and possibly this is a very much rational approach for attacking the multiple roots. So single polypill conundrum, we will have to accept that as a rational approach. Now next, let's come to some mind aspects while dealing with the roots. As you know, that the founder president, B.C. Rai, had tremendous capacity to diagnose a patient from a distance. And it is a phenomenal thing. And all these things may not be replicated in all of us or many of us. And that's why possibly there is a role of augmented intelligence and digital technology, which will help not only finding out the roots, but also they might influence the treatment schedule in the form of advising on exercise, in the form of advising on the diets, and so many other things. So digital therapeutics is a very, very important step in that direction. And as I am mentioning about the teleporting, teleporting is a mechanism by which actually I am giving a lecture here, and you can actually find me there in your in your place, in your chamber itself. So that teleporting will change the paradigm in the management of all the diseases. Now, over and above this, possibly the addition of the genomics can actually add to the flavor of the digital technology and artificial intelligence. And when we combine all this together, actually, whatever I am discussing, this is called the translational medicine or precision medicine, and that's actually the going to change our concept in dealing with the patients with the help of this. Now, while talking about the mind, is a very, very good gift from India that yoga actually can take care of many factors, what I have mentioned in the behavioral or fixed form of these risk factors by improving the circulation, then stimulating the insulin secretion, reducing the cholesterol, triglycerides and all, and positive effects on mood and stress, and all this can be actually taken care of by yoga. This is just one part of the story that along with the drugs, we will be combining the methods. So there is a great distance in the world that is the 14 inches between the mind and the heart, and it's a very difficult task to balance between the two. But there are great minds like as I have shown, Fariz Murad, they are great minds to stimulate all of us, all of our brains and minds. And of course, books are there to stimulate your minds and brains, and that's how actually the things can progress in a very, very important direction. Now this, talking about the mind, I always try to say about the COVID, which has actually challenged the health system. Now, it has not only shown the challenge, the negative sides, but it has also the positive sides by promoting the leadership in a different way. And you cannot go back. You have to come forward. You have to treat the patients, control the damage. And that's how actually you can actually give a very much structured kind of leadership for betterment of not only a society, not only the roots of the diseases, not only the organization, but even to your family. So my take will be that a leader should have the quality to inspire others, to inspire the next generation, so that actually they get stimulated to do the things in a better way. That's my last slide. This is the wheel of time actually. This is the wheel of time. And this wheel of time actually depicts that this is the root. Innovation is the root of not only doing good to our bad roots. So innovations all throughout the period since the universe has been actually generated, from molecules to, the tissues, organs, life, plants, and all this. So innovations actually led to the concept of increased resilience, and that's actually known as the evolution. And when there is increased resilience, there is increased survival, and that actually changes the quality of the leadership. And that leadership ultimately takes up the challenge to go for newer innovations. And when the newer innovations come, again the vicious cycle is there, and naturally that vicious cycle will lead to not only finding out the roots of diseases like the cardiovascular diseases, but also will give you the impetus to treat the roots. So with these few words, I thank Cardiological Society of India for giving me the opportunity to stand before you for giving this presidential oration. Thanks and pranam.
Thank you, Dr. M.K. Das, for a scholarly oration. We have with us Dr. George Cherian, very senior past president of CSI and chief of cardiology at BMC Vellore, who I would like to make some comments on the oration. Dr. George Cherian, please.
Am I audible?
Yes.
The only thing that I would have to say is that I want to thank Professor Mridul Kanti Das for an educated, interesting, and inspiring oration, fully worthy of the sort of work that he has done, and particularly what he has done during this very hard year. Thank you and congratulations.
So, namaste, sir. Namaste.
Thank you, President, and we will conclude the session. Thank you very much.
Thank you very much. God bless you. Forget
Good evening, Dr. Thomas Alexander, Dr. Sarchand Anandya. So we have just about another 5 minutes to start. The AGM is also just about closing. Dr. Thomas, you are muted. No, I cannot hear you. Sorry, just a second, sir. Yes, sir. Please, Dr. Alexander.
No, I was wondering whether the AGM was live or...
We were not supposed to give it live, they said. It was a physical it was a physical meeting.
Very convenient.
Sir, Dr. Shantanu would be the last speaker in this session. He's requested to be the last speaker in this session. So Dr. Girish should be the first speaker in this session, sir.
Okay. So Ajit, why don't you go ahead and invite the first speaker?
Okay, so maybe we can start now. I think we have 4 lectures here, and I think Shantanu is elected to go the last. So I'd like to call on Girish, who would talk about how to get the best out of the government-facilitated insurance program for improved revascularization in STEMI. So again, Girish needs no introduction. He's very active in the government hospital at the front, and so please go ahead, Girish.
Thank you, sir. If I can share my screen. I think I'm visible.
Yeah, we can see it. We can see it. Go ahead.
Yeah, thank you so much. At the outset, let me thank the organizers of the National CSI who have given me, I would say, a little bit interesting topic, out-of-the-box topic, how to get the best out of government-facilitated insurance program for improving revascularization in India. As you know that only 1 in 5 persons in India have the affordability to take proper medical care. And the delay in STEMI care is usually because of lack of affordability or lack of health insurance. And it results in a high out-of-the-pocket expenditure, which is a catastrophic spending for many, and so much so that 25% of these people actually become into the category of below poverty line. The public sector contribution for insurance is much lower than sub-Saharan Africa. So this lack of health insurance leads to reduction in revascularization, thus reducing the outcomes. So what if we have a good health insurance schemes? Do we really have a good outcomes? So this is an interesting study from USA, that is affordable care, Medicaid expansion. What it has shown is the access and utilization of care generally increases, leading to positive health outcomes. But however, in acute myocardial infarction, there is no association between Medicaid expansion and access to PCI hospitals or treatment with PCI. However, you can see that the hospital readmissions rates were reduced by nearly 10%. This Medicaid expansion program is very active in California when compared to other states in United States of America. So one of the important barriers for revascularization therapy is health insurance reimbursement policy. So before going to the improvements in health insurance, one should understand what are the types of health insurance which are available in India. One is employer mandated like CGHS, ESIS, and commercially or voluntary health insurance, community-based health insurance, and government-funded health insurance. I will be talking about government-funded health insurance. There are a lot of shortcomings of government-funded health insurance, like awareness is low, population covered is very, very low, increased hospitalization charges, but the benefits which were set way back 15 years down the line is being constant. There is 25% increase in the OPD cost, and sometimes administrative problems like the delay in getting the card has resulted in denial of services to the people who are holding the cards. So the healthcare scenario, once the PMJ had started in 2018, has started a little bit, it has started to show improvement, and the scheme now has become a little bit comprehensive, and the healthcare organization availability needs to be increased or improved, and so that the reach of the scheme is go to the grassroots level, and financial benefits of the financial benefits to the beneficiaries would be maximized. More, it has already been increased up to 5 lakhs by PMJ. More needs to be done. So what exactly is the true picture? This paper from Indian Institute of Studies in Industrial Development by Shalendra Kumar Huda, and he shows that this was published in, it is yet to be published in December 2020. He showed that health insurance expenditure and the percentage of the total health expenditure has remained constant for the past 20 years nearly, and budgetary allocation expenditure on Rashtriya Swasthya Bima Yojana is decreasing. It was 1,000 crores in the year 12-13, but now it is only 155 crores. Number of persons covered has increased, but the last 3 years it has remained by and large constant. There are increased number of dropouts from RSBI, nearly 15 out of 27 have dropped out, number of states, and there is heterogeneity in penetration with states like Kerala, Chhattisgarh doing the best, and Bihar, UP performing the worst. And the number of uninsured would be 25% to 99%. Best performing is Andhra Pradesh, only 25% are uninsured, and 99% of people in Bihar are uninsured. There is one should have a reality check. But the claim by government and the reality, what the reality is the difference is nearly 65%. That is, the reality shows that government has increased the numbers by 65%. While the reimbursement rates is reducing, the insurance companies are profiting by this because the premium has increased over time. So, with the idea of improving the healthcare system or universal health program, Pradhan Mantri Jan Arogya Yojana had been started under the aegis of Ayushman Bharat in 2018. It covers rupees 5 lakhs per family per year. The number of people in a family can be varied, and states can be given flexibility to discern the mode of implementation, and benefits will be portable across the country. So a person living in UP can have treatment even in the other states, which is actually having this program of PMJ. As told that annual benefit is up to 5 lakhs, no limit on family size, and implementation through insurance, trust or mixed modes, and convergence with the state as well as health scheme. These are the various packages which are included on PMJ. Initially it was only for the treatment, now it has increased to pre-hospitalization, it has increased to intensive, non-intensive care services, implant services, accommodation, food services, and post-discharge nearly 15 days for medicines also are included in this insurance scheme. But still more is needed for comprehensive health care for acute, at least for acute myocardial infarction. Then the mode of implementation is either it is insurance or assurance mode or mixed model, and trust, as you all know that trust is usually a non-profit organization. The awareness and sensitization of how the government works is more, but it has a weak in-house capacity and weak governance model, whereas insurance has more experience and more in-house capacity and structure. What we need is, we need a standardized treatment guidelines, standardized package rates, and updating and registry of lots of hospitals in the network, and IT integration and data generation is of utmost importance. Has PMJ really helped us? If you see, this is the paper from Chhattisgarh which has shown that despite PMJ, the out-of-the-pocket expenditure is still around 3,000 to 5,000 rupees in a government hospital, in a government setting, and around 8,000 to 20,000 in private setting. So it has not been able to improve access or financial protection to the beneficiaries. So now a lot is talking about the cashless system of Rajiv Gandhi Jeevan Dahi Arogya Yojana in Mumbai and in Maharashtra. it is really not cashless. As you see, the number of people usually spending on out of the pocket is nearly 25%, and the amount is nearly 5,000 rupees per individual, which is predominantly for medication, diagnostics, and consumables. So you know that for a good government-funded health insurance, you have to have a robust system. So you know that there is an insurance system, but this insurance is like an X in an X-ray. That is, it is not visible. So more needs to be done to make it more visible so that more people will come to know about it, be it in print media, be it in electronic media, be it in IT-based or internet-based, World Wide Web. So they are there, the insurance is there, but where are the patients? There are a lot of people who can be identified from the group, and they need to be enrolled in this universal enrollment. Universal enrollment should be universal, unlike the earlier insurance systems where there was skimmed enrollment. That means only people who are healthy were included in this health system. So this process should be done only once. It can be done at the first admission, or it can be done in the PSCs or community health centers. So the patients are there, the beneficiaries are there, but where are the facilities? So at each level, whether it is level 1 facility of acute MI care, level 2 facility of acute MI care, level 3 facility of acute MI care, there is lot of things are desired, like especially in level 1 and level 2, where there are not many hospitals which are empaneled. So hospitalization is really less, 6 times less in areas where there are no empaneled hospitals. So a strong hospital network is required. Not only a strong hospital network is required, the basic equipment in the hospitals as well as the basic healthcare facilities, healthcare workers should be posted in these facilities. And you know that it cannot be one pack for all. So this insurance has to be tailored to the ground realities. So it would be different from level 1, level 2, level 2 acute MI centers when compared to level 3 or level 4 and level 5. So it should be tailored. So it should take the help of technology so that you have a very simple registration process to increase the number of empanelment of hospitals. The verification of beneficiaries should be based on biometric system, and the transaction in hospital should be very secure and in real time, and portability of services should be enabled anyone, anywhere, anyone and anytime. And grievance redressal should be multi-channel with one single hotspot, and fraud prevention and prevention of cheating should be emphasized upon. Additionally, there should be minimal essential drug and device pricing. Implant pricing, as you all know, has already been achieved, but still a lot has to be done on balloon wires and even guide catheters, and improper enrollment of people, which ensures in inequity and inappropriate utilization of government funded health insurances, like that needs to be rationalized. And like if I'll give an example, in Delhi, whatever may be the insurance status of the patient, whether he is privately insured, or he is from CGHS, or he is from railways, or he is from ESI, everyone is given free treatment except for the implants. So there is no rational use of the funds available to the center. And inequity, the possibility of greater utilization by the rich, it's our experience by the past, and this can be prevented by demand side cost sharing, that is deductibles and co-payment for very rich patients and rich patients. Poor may be exempted from this. Private providers should be paid on capitation basis, that is a fixed amount of money per patient per unit time paid in advance to the caregiver, be it for a OPD, be it for an inpatient, or be it for diagnostic related or inpatient care. And for public providers, more autonomy and incentives are required. So where are the examples that by doing this we will actually improve the health system? Thailand in the late 20th century, with the help of a strong political will, which emphasized on emphasis on equity in health, so they were able to reduce the population not covered due to staff deficit and relative deficit in per capita health spending, and percentage out of the pocket expenditure also was minimized when compared to other countries like India, Sri Lanka and Bangladesh. Another example is from Chile, the Universal Health Program, that is AUGI program. That this is acronym in Spanish. And 1 year survival rate after the introduction of this universal health coverage in Chile has actually reduced the survival rate by nearly 4 to 5%, which is very significant one. So any program should have a SWOT analysis in the form of strengths, weaknesses, opportunities, and threats. For any analysis, strength analysis, the expanded approach or universal approach should be the goal, not only for BPL or those kind of income-based or cash-based enrollments. And seemingly high level of political commitment is required. This is of utmost importance, and well-functioning primary health care, which all possible treatment facilities available for at least the basic health care like ECG, X-ray, and BP instruments, and minimal infusions, and those kind of things should be available. Acknowledgement of linkage between the better health and economic growth of India should be of, it is a known truth that if your health becomes important, the economic growth is automatically bound to increase. Outpatient visits are usually not covered. You should try and cover this also. Transport to and from the health facility is of importance, because for very poor people, because this might be one of the hindrance in seeking the treatment. And liability to impersonation, one has to be very careful. Use of biometrics should be of utmost importance. And we should also involve private sector and insurance sectors. And opportunities, we should align this program with the other national programs. And universal, you should remember that universal health care is about everyone and everywhere. The threats, as expected, will be change in political leadership. One political leadership today requires this, but the next political leadership might have a different ideas. So limited buy-in and interest by the Indian states have, because the states have own schemes, they should be tried and be brought upon on the table on a same level. And there is challenges in low and mid-care level providers. So concluding, just universalizing the health insurance is not sole the answer for revascularization in acute myocardial infarction. Needs major revamping of governance, management capacity, infrastructure upgrade, management information system, a workable regulatory framework, and last but not the least, even the preventive cardiology aspect has to be included in this framework, so that the incidence and prevalence of acute myocardial infarction and other cardiovascular disease is reduced. Thank you.
So thank you, Girish. So I think we'll make the discussion at the end of all the 4 presentations, so that there's time to take all the topics. So thank you for a nice presentation on the issues related to coverage. And I think it is a very important topic which we may need to go into further. So maybe Sarath, you can invite Thomas for the next lecture, Sarath.
Okay, thank you. Thomas is like the doyen of ST care along with Ajit. So it's my pleasure to invite Thomas to give his talk.
Thank you. Thank you, Ajit. Ajit and Sharad. What I'm going to do in the next 10 minutes is not just talk about the barriers, but also talk about possible solutions. Because we always talk about barriers, and I think we get stuck there. And this is from our experience with the STEMI program. When you talk about barriers, there are, of course, 3 ways of looking at it. One is patient-related. The second is with regard to treatment in hospital. And then putting all this together into a system of care. Now, the patient-related barriers, what have we done in the states where we have started this program? One, we have used digital tools. This is a handheld, an app which we get people in that locality to download, basically informing them about the closest STEMI-ready hospital, talks about symptoms, and helps them to locate the closest hospital. The second is to accredit hospitals which are part of the program into accredited heart attack centers. And these are big boards which are put up. There are posters in the hospital to say that they are heart attack ready and that they are accredited by STEMI India. What it also does is that in the locality that they are present, it helps people to understand that if you have a chest pain, this is the place to go, and really reduces the door in, door out delay that happens when you go to a non-STEMI hospital. If you look at what has our achievement been in the states that we have rolled it out, primarily Jharkhand, Gujarat, Tamil Nadu at this point in time, I don't think we've made a huge impact on that. But what is going to happen in Haryana, where we're just starting our program, is this information, education, communication. This is, they call it ICE, which is a WHO document where the state government, now what has happened is the state government has said, we are going to do this part of it. We're going to set up the posters, we're going to do the brochures, we're going to send education sessions either in radios or TV spots, and we will do that as a state program. So initially they asked us to do it, but in Haryana they're now saying, let's do it for you because we have access to radio, we have access to telecommunication, and we will do this. And maybe this could make a huge amount of difference. The affordability issue about the health insurance scheme, I won't touch on that because Girish has done a great job about that. But I think this is absolutely important for equity in healthcare. And when I talk about the large number of our population we require. The second barrier is in terms of in-hospital treatment, whether it's thrombolysis, pharmacoinvasive, or primary PCI. And this is the easy part of management to train doctors. So I won't touch on this at all because I think this is the easy areas. But I think the third important part is how do we set up a STEMI system of care? And uh, and when you talk about a STEMI system of care, you need to think about the whole gamut of services that need to be in place, starting with the ambulances, the hardwares that need to be located in the peripheral hospital, the software which sort of integrates all this, a way to make the ECG diagnosis, the protocols, the training, the analytics, and finally the governance, where you need each stakeholder to be part of this program, whether it's the state government, the doctors in the hub hospitals on the spokes. And this is the whole system of care that STEMI India has managed to put together. And in the states where we are at the moment setting up these programs, we have all this as a package which we offer to the state governments. A word about the ambulance services. I think there was a time when I used to think of this as a huge success. It is a success, but there are huge gaps in services. The training is inadequate, and I feel that the 3-month training that 108 services do is not adequate. There is a very high attrition rate of the paramedics, and new recruits have to be constantly retrained. Utilization of ambulance for chest pain is very low, though for trauma as well as for maternal and child health is fairly high. And inter-hospital transfers, we need to work with the governments to get it done because it's not part of their mandate. So there are huge gaps in the 108 ambulance services, but working with the governments, it is possible to work on this. This is a paper, Girish alluded to this, the white paper that was published in Circulation, Resource and Infrastructure Appropriate Management in low and middle income companies. And Chandra, Ajit, myself, and Jagat Narula wrote about 95% of this paper. And really, this sets the scheme as to how we're going to look at the deficits that are there and make use of the infrastructure that is truly available at the point in time and utilize that for managing heart attack. And that's, I think, our challenge at this point in time. Not to look at what is the utopian or the ideal way of managing a heart attack, but look at what is the infrastructure, what are the resources, what is the what the skill available with the doctors at this point in time in a particular geography, and then can we set a STEMI system of care utilizing that. Clearly not the ideal situation, but certainly better than what is available. And the objectives of this technical report was to talk not just to the doctors, but to talk to governments, to talk to NGOs, and to try to get a composite way of managing heart attack across the country. So what it does is to identify gaps in current strategies, look at where investment and resources should be applied, and to look at large-scale strategies to develop systems of care. So when we talked about it, we said there are 5 levels that we could talk about. So let me just walk you through this. What is the level 1 facility? And this we talk about a general practitioner level. He may or may not have an EKG, and he might have some basic drugs available in his hospital, certainly no thrombolysis. So if a patient either walks in or by ambulances arrives there and there is no ECG available, still if he comes with chest pain, which is suggestive of an MI, give him a soluble aspirin. If it looks like there's a very high index of a suspicion of an MI, then move him to a reperfusion center. If not, move him to a center where an ECG can be done, maybe a lab or a small hospital that is adjacent to this private clinic where you can get an ECG and then see if it's STEMI is confirmed and then move him to a reperfusion. So this would be a level 1. A level 2 would be something higher, like a GP practice or a small hospital may have an EKG available, some medicines, but certainly no thrombolytic. And you could think about a community health center, something like this. So this is basically, we talked about this as a community health center. Again, it could be a walk-in or an ambulance transfer. An ECG is done. If the ECG, you can make a diagnosis, the doctor is confident of making a diagnosis, then he makes a diagnosis at that point in time. Or if he has the ability to transmit these ECGs to a higher center or a tele-ECG facility, if STEMI is confirmed, then use aspirin, clopidogrel, high-dose statin, and then call an ambulance and transfer. On the other hand, if STEMI is not confirmed, what we suggest is do a troponin if available, repeat ECGs every 15 minutes for the next 1 hour till either you rule out or confirm STEMI. Level 3 is a fibrinolytic center. So this is like a district hospital that we talk about. So a patient arrives here. If you do an ECG on arrival, if STEMI is confirmed, you give them the aspirin, clopidogrel, statin, thrombolyze. If thrombolysis is contraindicated, you move into a PCI center. So this is really a thrombolytic center, which any district hospital, we can train them to do this. And we're doing this as part of our program in Jharkhand. This is the model that we have there. So we have these spokes, which are thrombolytic centers. But one important thing that we have incorporated there is we have a tele-ECG facility. So the ECG is done there. It's done, the ECG is read either by the hub hospital or by a tele-ECG service that STEMI India now has. You can confirm STEMI and then is thrombolized locally. Is only referred to a referral center if he has cardiogenic shock, failed thrombolysis, or has hemodynamic or electrical instability. We are now at this point looking at a different model where we are trying out a tele-CCU way of hand-holding the district hospitals. And this is a pilot project that we are at the moment starting. The level 4 facility is a PCI capable center, and here this would be like any PCI center. If it's a government hospital, what we also say is if PCI is not possible within the time limit that a patient, either due to cath lab, delays in the cath lab, or cardiology is not available, then do the pharmacoinvasive even within this center. And finally, the level 5 is what we talk about, the typical hub and spoke model. And this is what we advocate in centers where we can link a hub to peripheral spokes, where thrombolysis is done in the spoke and the pharmacoinvasive treatment and primary PCI is the way to go for. But one thing that we are now trying to push is to get a public-private partnership. So where government hospitals cannot handle them, we have a secondary hub in the same locality, which is usually a private hospital, but with Ayushman Bharat accreditation, so that those overflow patients are moved to the secondary hub for treatment. This recommendation from our white paper in circulation also looks at how do we look at the ideal recommendation or aspirational steps that we need to do in terms of ambulances. We would like EKGs with transmission capabilities to be part of the system of care. We would look at NGOs and IT industry working together with us. In terms of EKG, we would want the primary health center and the community health center to have low-cost portable ECGs with transmission capabilities. We would want biomarkers to be available in these areas. And in terms of medications, we're trying to push governments to use third-generation lighting. And this is what is happening in Jharkhand, because we find it very difficult to train youngsters or new centers to use streptokinase. But it's easy to do. Thank you for your attention.
Thank you, Thomas, once again for an absolutely superb talk, which takes the, the clear requirements, what we need to do to build a system of care. And I'm sure we'll have a discussion at the end of the session. And I
Sir,
think
sir, just a second, sir. Sir, next we are going to Dr. Shantanu Kua because Dr. Hardika has some connection problem, so we are rectifying that, sir. That's why.
okay, so maybe Samir is with us now. Samir, so welcome to the meeting, and can you help us to invite Shantanu Guha for this lecture, Samir?
Absolutely. Dr. Guha, a pleasure inviting you to this session. You have led so many of the CSI initiatives, personally guided me. It's a pleasure hearing you and inviting you to the meeting.
Thank you, Samir. Thank you very much. My talk is on STEMI network in India, what CSI can do. The previous speaker, Dr. Alexander, has very elaborately discussed about the STEMI India's programs and how they implemented it. I will look in a little different way because we do not have any direct involvement in the formation of any STEMI network. We can only act as an advisory mode. Looking at the epidemiology, let me start with this introduction. We have a very high incidence, around 3 million per year. It is the predominant form of ACS. We have earlier age of occurrence, around 10 years earlier than our Western counterparts. There is a significant male preponderance. We get ACS at a lower LDL level, and we have high case fatality rate. There are several hurdles in the STEMI management. One is delay in presentation, lack of proper transport, suboptimal reperfusion. Pre-hospital thrombolysis mandates the presence of a doctor as per the Indian legal system. Inadequate cath lab availability and non-informed distribution of the cath labs. Non-adherence to GDMT both in the hospital, during the hospital and follow-up treatment. Financial factors and lack of public awareness, to name a few. The delay in presentation is way above the time recommended by the Western literature. In India, the shortest time was reported by the Kerala ACS registry, which is 4.5 hours median. Regarding the mode of transport, this slide shows the horrible state. Ambulance is used by overall 5% of all the patients, rich or poor alike. Mostly the privileged ones use their own transport, while the underprivileged ones use the public transport to reach a hospital with ACS. Suboptimal reperfusion, this is a pity that only 41% of the STEMI patients coming to medical contact receive reperfusion. Thrombolysis is the most frequent mode of reperfusion, mostly with streptokinase. There also we have worrisome thrombolysis practice. Kerala ACS registry reported that 19% of the STEMI patients and 10% of the unstable angina patients receive thrombolysis. Primary PCI is available to less than 10% of the STEMI patients coming to medical contact. And even when available, its utilization is limited by several other factors. Looking at the reperfusion utilization, the two most quoted registries in India, CREATE and Kerala ACS. In CREATE, the total reperfusion was 66%. In Kerala ACS registry, it is around 53%. Looking at the intervention in acute MI, this is our NIC data. In 2018, we performed 57,500 primary PCI. 2019 data is not available because of the COVID. If we look at it, this figure corresponds to less than 2% of the total MI which occurs in India every year. That is, if you take the figure at 3 million. Coming to the availability of the cath labs, considering the Indian population of 1300 million, there is one cath lab for more than 1 million people. More than half of these centers have no surgical capabilities. This brings us to the concept of the STEMI network, which has been adequately and elaborately discussed. I'll just go through it. Its main purpose is early and pre-hospital diagnosis of STEMI, early transportation, which leads to decreased time to reperfusion and increased reperfusion rates and decrease in hospital mortality. It facilitates early diagnosis and thrombolysis or referral to a PCI capable facility and significantly improve clinical outcome. The Tamil Nadu STEMI project was the pioneer in this field, and it was done by the same group of Dr. Thomas Alexander, Ajit Mulasari. Here, in addition to the STEMI project, they compared the pharmacoinvasive approach with the standalone fibrinolysis using mostly streptokinase, and they could bring down the mortality from 9% in hospital to 1.7% in hospital mortality in this particular project. And this has already been discussed by Dr. Alexander elaborately. I am not going into it. And we need to look at the ground reality in India. In the rural areas, the distance to the nearest hospital varies from region to region. It is perhaps best in the South India and inferior in other regions. And if you take the all India figure, this is around 17 kilometers on an average one need to travel to reach the nearest healthcare provider, which is mostly a sub-center, not even a primary health center. We proposed our own scheme for STEMI management in India in our position statement. That depends on where the patient is presenting. If the patient is presenting in a big city, he has the option of going for a primary PCI, or if not possible, for hospital-based thrombolytic therapy and subsequently for pharmacoinvasive ones. If the patient presents in a small town, hospital-based thrombolysis should be advocated and patient can go for a pharmacoinvasive later on if feasible. But what about our villages? There is no hospital nearby. Here the thrombolysis in a nearest hospital may be the destination therapy for a majority of them, and the vast majority do not receive any treatment at all. And a lucky few can be taken up for pharmacoinvasive therapy. So what CSI can do in this scenario? It cannot implement plans directly to uplift the STEMI care. It can bring forward some proposals of plans and discuss it with the authorities or stakeholders so that they get implemented. What we can directly do is can organize training and orientation program for physicians and other healthcare providers, and can participate in improving the public awareness, which is of paramount importance. We can only give some suggestions for early detection and early treatment. There should be a better transport facilities to reach nearest healthcare provider. ECG during transport or at the center of primary contact. Use smartphones and telemedicine for prompt ECG interpretation and initiate reperfusion therapy whenever feasible. Ensure early thrombolysis by making subdivisional and rural hospitals or hospitals in smaller towns thrombolysis capable, and adequate supply of thrombolytic agents. These are the few suggestions we can put forward. For quick transfer to tertiary care of PCI capable centers, it should be a priority for a group of patients like those within the specified time window, provided they can reach in time. Patients developing hemodynamic instability or failed thrombolysis, or for pharmacoinvasive strategy. This requires a very strong network of ambulance services, which is lacking in most part of our country. There are some suggestions for developing the adequate PCI facilities uniformly across the country. Most cath labs are located in metros and large cities. More cath labs in smaller cities are the need of the hour so that more patients can be treated there and there will be less transfer to the big cities. In this regard, focus should be both on private as well as government sector. Round-the-clock cath lab availability is another very important factor, particularly so in the government institutes. Most of the government institutes have fixed office hours cath lab services and that they do not operate during the night time. Proper communication network among cath labs and ambulances to avoid delay in primary PCI is also very much important. How to have the distribution of the trained manpower and use of telemedicine. Perhaps our dearth of manpower is now decreasing very fast. We are having around 350 DM cardiology and 100 DNB cardiology students passing out each year, so a pool of 450 to 500 every year. Their uniform distribution throughout the country will help to improve the STEMI care substantially. For telemedicine, helpful for early diagnosis and treatment initiation, short and long-term follow-up of patients after initial hospital care, and especially they are helpful for patients from semi-urban and rural areas. For utilization of financial resources, treatment of STEMI often becomes prohibitively expensive. Introduction of some central government schemes like Ayushman Bharat and several state government-run schemes like Shastro Sathi in West Bengal, they have helped many patients below the poverty line to avail insurance facilities. Widespread awareness and implementation of such schemes will vastly improve the STEMI care in our country. And last but not the least, the generation of the public awareness and education. It's a real challenge in a country like India. Self-diagnosis of ACS as gas and treatment with antacids are quite common. Print, electronic, and social media should be used in best possible ways to make people aware about the symptoms of MI, where and how to seek help, and risk factors and their control. So to conclude, STEMI network in India should be an integral part of the overall healthcare system. 67% of the population lives in rural areas, having 25% of the hospital structures. Majority of the STEMI patients don't receive any treatment. It is simply not possible to create a uniform STEMI care network across the country. Most of our rural hospitals and hospitals located in subdivisional towns or smaller towns are not even thrombolysis capable. Vast majority of our cath labs are located in metros and large cities. Hence, our first priority should be to offer some form of reperfusion, mostly thrombolysis by streptokinase, to our rural patients. Setting up a network for primary PCI may be tried in urban areas. Selective pharmacoinvasive strategy may be employed for those successfully thrombolized. Widespread utilization of government-run schemes will uplift STEMI care in our country. Proper use of telemedicine should be implemented for treatment of semi-urban and rural areas. And public awareness using different forms of media holds the key. Thank you very much.
Thank you, Dr. Santanu, for a real nice overview of what are the problems and what CSI can do. Is Dr. Madhikar?
Yes, I am here.
Oh, yeah, good. So let's finish his lecture and then we go on to the discussion. So Dr. Madhikar will tell us about the have we reached the limits for primary PCI capabilities in India. So go ahead, Madhikar.
Yes, thank you, Ajit. There was wonderful presentation from all the previous speakers, and organizers have asked me the most difficult question to answer. Have we reached the limits of improving primary PCI outcomes? Yes, it's a difficult question, but I will try to answer it in the best possible way. But let me at the beginning say that cardiogenic shock is excluded because this is a totally different topic which needs to be discussed. This photograph and gentleman doesn't know any introduction, Dr. Ashwin Mehta. And in very early days of acute myocardial infarction management in San Hospital, I got interested into it. And today's reflection is based on last 22 years of AMI management.
So first study was published in San Hospital about San Hospital thrombolysis trial, where I was working as a resident doctor, but got a lot of insight into what happens in AMI management. And this study can be worth revisiting, which shows that inferior wall has more mortality as compared to anterior wall in MI, which should be worth revisiting again sometime in future. Our interest in ST elevation never decreased. So even the other study which we did was on ST elevation and exercise, which we thought was another interesting topic, especially after the AMI. The stress test was very common. And third was coronary artery stenting in AMI, which was done in 1997. So what I talked today is a reflection of last 20 years. So let's focus on ST elevation. This is the most important thing what you see in acute MI. Then I will touch upon a little bit of biomarkers and discuss about platelet activation and other factors. So you see on the left-hand side is the ST elevation, which represents electrocardiographic hallmark of coronary occlusion. And on the right-hand side, what you see is the typical resolution of ST segment, which we are happy to see when patient responds to reperfusion therapy. Let me take you back again to 20 years. There's only one study which has evaluated ST segment resolution as a topic, and it was published by none other than Braunwald. This article looked at very nicely of multiple studies published at that time with reperfusion therapy, and what it showed that if ST resolution was complete, the mortality was lowest, and if it was none, the mortality was highest. So the real hallmark of successful reperfusion, though it is very difficult to diagnose at bedside, we believe that ST segment resolution remains the best hallmark of mortality after the successful reperfusion. This is a little complicated slide, which at one slide on the left-hand side is TV14 study. This is on another study at HIT4. And if you look at this, both the slides at ST resolution, 79% of patients in the TV14 and about 70% patients in HIT4 had complete ST resolution, but TIMI3 flow did not happen in all. So we are very happy by seeing TIMI3 flow in primary PCI, but possibly that does not mean that all the things have happened well and patient is going to respond and I will have a low mortality rate. So TIMI3 flow and ST resolution should be the criteria to look at acute MI. So I've just touched upon very basics. My question to which I need to answer is, have we reached the limits of understanding of a research of improving the primary PCI outcomes? I think if we focus on ST segment resolution as the most important outcome along with TV3 flow, possibly we will be able to reduce the mortality in the best possible way. So there is one study which I picked up again from this article, which is very interesting, and it talks about the role of epsiximab. Though we know that larger studies of the epsiximab were not able to show the difference in mortality, but what again, if you look at a very immediate outcome of acute MI, those patients who underwent with epsiximab and without epsiximab, there is a difference in ST segment resolution. So those who believe in glycoprotein 2B inhibition in general and epsiximab in particular still should be looking at this, using this drug sometimes in the acute MI angioplasty. I do it reasonably about 50% of times. Now let's move on to the biomarkers. We looked at ST segment elevation. Now we'll move on to the biomarkers. One of the very early studies published in 2006 looked at NT-proBNP, which is now very commonly used as a biomarker of heart failure. But what this study showed was in patients who underwent only thrombolytic therapy versus those who underwent thrombolytic plus PCI, immediate PCI within 24 hours, and those who underwent direct PCI, that is primary PCI, NT-proBNP was more raised in patients who underwent PCI as compared to those who underwent lytic therapy first and PCI afterwards, or only lytic therapy. This makes you start thinking what happened to NT-proBNP, and sometimes I believe that it was lost in the jargon of what this study published. It's an interesting study, and this biomarker has come to another level of attention again when I was searching the literature for this presentation. And this study is published by West Trial, which early therapy for ST MI by Professor Paul Armstrong. And his group also now come up with another interesting study, which looks at novel biomarkers, ST resolution, and clinical outcomes following primary PCI. It's a small study. It is not a large randomized trial, but it can give you enough insight into what happens. And if you look at the bottom of the table, the NT-proBNP, there's significant p-value. So this is not the marker of successful PCI in this subgroup of patients. When patient presented with high levels of NT-proBNP, what it needs to understand is outcomes are poorer. So patient to present to you with a high NT-proBNP, it is some kind of very high amount of stress at that time in myocardium, which is reflected by raised NT-proBNP. Nothing that we can do at that time to reduce NT-proBNP, but if you can measure this biomarker quickly at the bedside before taking patient for angioplasty, it suggests high mortality or at least high morbidity. And this is interesting. And the other point, which I'm going to touch little later, is the platelet activation in this subgroup of patients. So in this trial, again, if you look at this diagram, NT-proBNP is to the left. More the NT-proBNP, worse the outcomes. But even platelet activation, which was studied by using P-selectin and the coagulation pathway by 1 Willebrand factor. So, and then the wound healing, as you go down, the other factors are not so important. Again, what it shows that second factor after NT-proBNP is platelet activation. And from earlier studies, you know that patients of diabetics have poorer outcomes as compared to non-diabetics. Possibly platelet activation in diabetics is more than what should happen in normal person after acute MI. And these two factors, stress, which may exist in myocardial dysfunction already, and the platelet activation should be responsible for the worst outcome. So this is the only latest research in the field of acute MI management. And I brought this study here because I have to answer the question, have we reached the limits? So there are not many studies in this field of acute MI management. There are some studies which we know about staging, which angioplasty, which vessel to do, how many vessels to do. But these are all protocols which you want to practice, but nothing great research has happened in the field of myocardial infarction except these two markers which we are seeing here, but we don't know how to alter them. So what are the other things which have been studied? It was biology of remote ischemic preconditioning which has been studied, which was thought to be very promising in management of acute MI. And there was a lot of enthusiasm, especially in the developing countries, because it needs no drugs, no cost. What you need to do is only inflate the cough in the arm and wait for 5 minutes and produce ischemia distantly, remote ischemia, and you precondition the myocardium. There's also post-conditioning of myocardium. So both the concepts appeared very interesting, but unfortunately, the trial which was done and which was published in Lancet in 2019 was negative, or it did not show any significant benefit. If you look at this diagram, it does not show much benefit, or there's nothing adverse, but it did not prove anything good. Now, why this happened? If you look from the Indian perspective, I will still think that this study was in a very advanced studies countries where all the things were perfect. Not in India, where delayed presentations are common, patient not receiving lithotripsy is also common. Possibly, if these subsets were included, the benefits of ischemic preconditioning could have been better. But now that study is over, so this subject has again gone out of research. But those who believe in this, they should look at this option of remote preconditioning. Promise of stem cells in 2002, it was appeared to be very promising, which this study appeared in Circulation from Germany, and it looked very promising. There was a lot of enthusiasm about stem cells, and the center started. I'm sure some India also, there were some stem cell centers going. It attracted attention in many degenerative diseases. But the status today is the stem cells are not working. Unfortunately, we must conclude that stem cells are not working. So what are the other options which are going on? We are looking at new stem cell types. We are looking at extracellular matrix. And we are looking at a chemical substance called algeron, which is not exactly chemical, it's derived from the algae. So algae have a very fast ability to grow, and they are looking at growing the myocardium with algae. Very interesting concept, but only future will tell you. Today's NIC data presented by Dr. Kahali showed 41% in this country only received thrombolysis, 2.3% received PCI, and 56.6% received no perfusion at all. So it is quite abysmally dismal. If you look at the problem which Dr. Shantanu Guha was elucidating to, and Thomas Alexander has tried his best to create this network, but it exists only in one city. So we must thank Thomas, and we also thank Ajit Molasi for doing this job, but I think we have not done adequately to improve the performance of early PCI or even thrombolytic therapy. So another interesting study I'm sharing from 2008 review in Lancet, which was published by Harvey D. White. And if you look at the top, no reperfusion in a million patients will have 270 more deaths, which is phenomenal. And as soon as you start improving everything, decrease in delay of lysis, decrease in delay of PCI, you start saving lives. But the most important part for today's talk is look at the lower level, novel therapy, which will provide 20% reduction of 30-day mortality, will be only saving one life. So I think any new therapy, whatever we may do, is not going to benefit much as to the population. An amount of money that we will spend in looking at the developing new therapies will be phenomenal. So somehow or the other, it looks that we are reaching the limits of what we can do exactly in primary PCI from research point of view. There's enough opportunity. All the speakers have elucidated that there is enough opportunity to do anything to decrease the delay in any kind of reperfusion that we are offering, and offering it to almost every possible patient who has a ST elevation in mind. So we move further with last few slides. What we can achieve the best quality is make it effective, right drugs, right procedures, make it timely, as soon as possible, make it safe, looking at the age of the patient, adjusting the dose accordingly, equitable, all the patients should get the same therapy. This is a dream in India. What affording patient will get and non-affording patient will get is not the same. It should be patient-centered and cost effectivity, avoiding over-treatment. These are the goals which Professor Paul Armstrong put in one of his slides in the CAD conference in 2017. And this is the slide I borrowed from him. So have we reached the limits of improving primary PCI outcome? That was the question was asked. My first answer will be yes. If the right therapy is selected at right time for the right patient, we have reached the limits of improving the outcomes. But unfortunately, across the globe and especially in developing countries, this is not possible. So a lot of scope in management remains. No, if you do the correct therapy in best possible circumstances, limiting the infarct size in spite of successful primary PCI still remains a challenge. And that is one area which probably we need to look into in course of time, limiting infarct size after successful primary PCI. We have not conquered this part of it because we have not been able to ensure TIMI3 flow and resolution ST segment 100% in all the patients. So next step will be preventing the plaque rupture. Two therapies look promising. One is PCSK9 inhibitor, which we are already using by reducing the lipid core at the center of the unstable plaque, and possibly therapies like SDL infusion, which has been tried. If these therapies succeed, we may have better outcomes by preventing the rupture and preventing the myocardial infarction. Thank you very much for your kind attention.
So thank you, Dr. Maldikar, for again important lecture to say what we can do better. I will now open this discussion to all the experts and my colleagues and on the panel to question all the speakers. In the next 10 minutes, we have maybe some discussion on these issues. So maybe we can start with maybe Dr. Sunita. Would you like to put a question to any of the speakers and then go to Dr. Shailendra, Ranganayak, Sarat Chandra, Samir, and Santanu?
Can you hear me, sir?
Yes, we can.
Yeah. So my comment is about Dr. Santanu's comment that most of the government hospitals do angioplasty only during the office hours. That's a primary PCI. So I don't know whether that is correct with regards to Kerala, because in Kerala, most of the medical colleges have round-the-clock facility for doing primary PCI. So we have teams set up and we have the nurses posted on call. Technicians are also available in the hospital. So we are able to provide the primary care. Even Sundays are covered. And right now, because Kerala is probably different from other states in the sense that it's a continuous township. And the government has extended the cath lab facilities to the district hospitals also. So I think last year some 10 district hospitals have been provided with cath labs. So that is one thing that has happened. And we perform around 1,500 primary angioplasties in our department. every year. But the sad thing, as Thomas Alexander sir has pointed out, is that I also feel is that the time to presentation is still it is delayed, and the total ischemic time is coming as 200 minutes plus minus 20 minutes. So I think this is the area where I think we need help from the STEMI India, or how to go about this. How is it possible? And I think basically you need a lot of guidance at governmental level, or maybe at the medical education and the Directorate of Health Services, to incorporate whatever Thomas Alexander sir has been telling about and the IEC activities.
My question is to Thomas. Thomas, what's happening? The state level programs like Arogyasri, vis-a-vis the Prime Minister's program, are they amalgamated in some of the states? Like, Telangana, they have not asked the central government to contribute. They say we can do it on our own. What's happening on this front? You should be knowing better.
Yeah, thanks, Sharat. Couple of points. Madhukar did mention that we are there only in one town or one city. Madhukar, we are in three states. We should have been in 6 states at this time, but the COVID epidemic, so 3 states have held back. But we're sure at the end of, by the first half of next year, we will be in 6 states in this country. Okay, many of these states have merged their PMJ program with the state level health insurance scheme.
Okay.
Really speaking, it was robust only in the southern states, and these are the states which have merged. For example, in Tamil Nadu, but in Jharkhand, where we now start the program, there is only the central government scheme. But as Girish had pointed out, there are huge issues with this, and we are talking to the central government as well as the health ministry to try to sort out some of these issues for the states.
Eventually, I think, there should be one program, because right now there is a lot of confusion, who is funding for what in some of these states, at least, where there's a state level program. I think you should work in that direction. There should be clarity in this, regarding funding.
I think basically the PMJ gives 60% of the money, and the 40% is chipped in by the state government. I think that's the way it works.
But I think the political will should be there, and there should be they should forget about their egos and sit together and come together, formulate one single sort of insurance program for all of India.
If I could just tell you a couple of things from our Jharkhand experience. In the PMJ health insurance, the OK takes almost 2 days to come through. And this is a huge problem. We're talking with the central government. In Tamil Nadu, it came within 10 minutes of start. If you get them a phone call, within 10 minutes, we'd get an OK to do the angioplasty. The reimbursement takes close to 3 months for them to get the money. So the state governments the hospitals are crying, saying that it takes three months for the money to come.
Why do you I would say,
that they have one insurance system for STEMI India, one insurance system. Cannot they? I mean, the CSI should recommend. I think that they have for STEMI India, because you save so many lives, and these people are in India. So many STEMIs are at the age of 40. So it's very important that this should be impressed upon the government, that they should have one insurance system for STEMI India, and then of course they have to develop the primary care hospitals where at least an ECG facility should be available, and with WhatsApp they can make a diagnosis. Even if there is a communication with any other hospital, they can make a diagnosis of ST elevation MI. Therefore, there should be an ECG and at least an ECG technician, trained technician there, along with an MBBS doctor who can diagnose the STEMI and directly refer the patient to the hospital where thrombolysis can be given.
I think one of the things that Dr. Shantanu mentioned, this could be an area where CSI could really push the PMJ to work like the Tamil Nadu or the Arogyasri works, so that immediate permission is granted for STEMI and the reimbursement is hastened.
Can Thomas, Ajit?
Yeah.
Just that the CSI also with in terms of the thrombolytic agent. I mean, I think, like Thomas, I think brought up that point. I think we should move from streptokinase to tenecteplase. I'm sure that as a policy, CSI can move the health authorities to try and make that cheaper and more easily available in terms of the side effects, and it will probably be much more acceptable. It's so difficult to train people to give streptokinase, mix it properly and give it, and the side effects. So maybe that's one other point that I think the CSI can take up, along with what Thomas has just suggested about, pushing the PMJ to make STEMI at least come into in all the states and integrating it. I think the choice of thrombolytic agents, I think, would also be a very important point.
I think that's a great point, Ranka.
I think that this is something we've been looking at a long time, though streptokinase is the commonest drug still used because of its cost. I think if the governments can negotiate hard with the companies for bulk purchase, just like the stents that they did, we can get these drugs at very, very reasonable cost, and I think it will make things very easy. Most physicians in the periphery are a bit afraid of streptokinase because they get the allergic reactions, they get the hypertension, you have to mix, you have to give an infusion. So I think getting Retiplase or Tenecteplase on board is something which is very, very important in this whole scheme of things, just like insurance, ambulance, and ECG facility for transmission. So I think this is something we've always looked at. We have a small study which me and Thomas executed with Retiplase facilitating pharmacoinvasive, and the ease of delivery was amazing for physicians. So I think this is the key that we need to work on at every area so that we reduce time and make it convenient. And that's the key for a system of care to work well. I have a question for Girish. What happens in Delhi? You're in the heart of things. You're in a big government hospital. How does PMJ work there? Let's ask that. Yeah.
Initially, the Delhi government was not willing to actually, be a part of PMJ. They have come on board only this year, and after COVID, we are yet to hear that whether they have implemented PMJ here or no. But in the Delhi government hospitals, but in the central government hospitals, PMJ is there. It's working. But I heard that there are some problems in the reimbursement to the hospitals, so they are not getting the remuneration on time. Plus, I have two submissions regarding the thrombolytic agents. Yes, we have done away with streptokinase. Most of our patients are thrombolyzed with tenecteplase, 80%, and 20% is by Retiplase. And I have two points to make here. So, as advised, Dr. Ajit, bulk purchase would actually, you will be at a very good, in a good position to bargain for the price. And I think it is now time to bring these thrombolytic agents in under drug price control. No, like any other, even for that matter, the implants also. Plus, I don't see there is financial constraints on individual state governments regarding the budget. I see a lot of budget being sent back unutilized at the end of year. So the utilization of budget, financial, that is the health budget, is not proper at the hospital level. I think we have to prime them, and you have to make them more towards the proper utilization of the funds which are at hand, so that you can get the best possible medicines at the best possible rate.
Ajit, I want to make a comment here.
Yes,
we are talking about all the government efforts, but what I see, at least in central India, around where I practice in Nagpur, is we are underestimating the efforts done by very young doctors. They've been trained at different hospitals, and they have moved to the periphery. And in a very resource limited setting, when I see the patients coming back to me for taking some opinion, so we must appreciate the efforts done by very young doctors. And I think CSI has to put in some efforts to reach to the smaller places, district places where there are no yojanas, but under the limited circumstances with limited funds. These young doctors, I believe, must have saved many lives. And this story is not coming up anywhere. because we only one focus on what government is doing. But India is a country where individuals matter far more than the government. The story of Indian success is individuals, not the government. That's a part of our country everywhere. So I think CSI has, I don't see Shantanu here, has a
Yeah, I'm
responsibility
here.
to, yeah, Shantanu, CSI has
Yeah.
to collect the data on small centers. I know your students who passed in Calcutta went to some small place and now they are doing primary PCI. Rather, their whole practice of interventional cardiology is primary PCI.
Is primary PCI, exactly.
That's
I
it.
just wanted
But
to
and I know some many
emphasize
young
on
guys
this.
who have served many lives in a distant place away from Shimla. So, like COVID warriors, we are very young warriors fighting the war. Try to get them somewhere, get that data, and that will be very interesting data to share.
Yeah, I personally feel the primary PCI using a bare metal stent would be cheaper than the your tenecteplase also. And if you tenecteplase and F6 it would be costlier compared to your primary PCI with just a bare metal stent.
Or even regulating stent, you don't need to spend so much of money when you have adequate labs and the young doctors ready to get up at midnight and do angioplasty. I think that enthusiasm to establish themselves in smaller places is saving many lives.
And
So
there
that
will
is
be,
all there, but the patients coming to the hospitals at the right time, sir. I think that is the major
Yeah,
problem.
that's right.
yeah,
That is the
that is
bottleneck.
always there.
That is always there.
Madam, just to respond to your comment that majority, I can tell you there are more than 80% of the government hospitals, the cath labs are closed at night. Because I myself, I have visited several ones. That may be an exception in Kerala, but you ask anybody elsewhere, I think more than 80% of the government hospitals, they don't function at night, particularly the cath labs. Secondly, regarding the Girish has said about the several schemes, a political will should be there. That is the first problem. Without that, we cannot do anything. For example, I give you one example. The Ayushman Bharat is non-existent in West Bengal, where I work. Whereas we do have a state scheme called Shastra Shati, which provides for all the expenses up to 5 lakhs to all the card holders. So had there been both the schemes, things would have been far better. Had it been amalgamated, things would have been far better. But a strong political will and preconditioning is required for that, which perhaps none of us can influence.
Okay, can I just add one point here? The other major area that we need to work on is public-private partnership. And this is something no state government is willing to touch. Wherever we go, they say, okay, make use of our medical colleges, make use of our primary health centers and community health centers. And we show them that, see, there are small hospitals here which are thrombolizing. Link them up. When the community health center becomes big, when the district hospital has facilities, we will certainly utilize that. But the political will for public-private partnership is not there. And this is another huge hindrance. And maybe CSI again, Dr. Shantanu, I think these are important suggestions, and maybe this is another area that you could use the CSI to push the governments to recognize and utilize.
Thomas, I have one question here. In our state, we find a lot of PPP models with MRI, with CT scans, with even in distant areas with digital X-rays as well. So why not with the cath lab? I don't.
Can I interrupt on this issue? So, with a brief interaction with IAS officers, me and Thomas, in multiple states, this is exactly the same question that comes through. And the governmental hesitation to do a private partnership, in a way, is basically because of the success of these models of MRI, CT scan. I had a very interesting discussion with a senior IAS person. And he said, see, doc, we have put in so many CT scans and so many MRIs. And the cost of now a CT scan in Tamil Nadu is some 300 rupees and an MRI is some 800 rupees or whatever, some number he said. And we could do this effectively. So why don't we do that also in the cath lab where, you can do the same story, and why at all we need to have a private business to cooperate? The difference here is a CT scan or an MRI or a diagnostic test needs a technician. and it can be peripherally interpreted a little late, with time being no constraint. But a primary PCI program or even a thrombolytic program cannot be managed by technicians. It has to be managed by physicians or cardiologists who are experienced in this area, who are available at the site and are timely doing the stuff. So it is not machine dependent, it is people dependent. And hence, our doctor dependent, let me put it more than people dependent. So if you compare a CT scan and MRI facility and partnerships of whether it is by public only or private public or private, it doesn't fit into a myocardial infarction program, which is more, people intensive, and in terms of times more intensive in terms of quickness, which is efficiency. And there is where the problem starts. So I personally think it's very important for us, individual doctors who are in the states, who are obviously CSI members, to now convince that we cannot expect a national CSI body to go to every state and start talking to every state. What we can only hope is that the local CSI, and I take Kerala as a great example of this, because whatever they've achieved is partly because, well, their health systems are much better. They are much ahead of most of the other states and even primary healthcare. But more importantly, the CSI has made inroads into, even you look at the Kerala ACS registry, it is a CSI driven local registry which has managed to collect that information of the Kerala ACS group. And I think that if all CSIs, local chapters, work in the same way, possibly we will do a good job and then amalgamate that into the national CSI together. And then the national CSI goes out and speaks to somebody. Because whatever we do, unless the local stakeholders and the local people, there are some leaders who can push the program in their own states, it cannot pan out into the whole country, which is so diverse and with so many different problems, different states, different politics, and different insurance schemes, which are obviously politically driven. I think that we'll all have problems. So despite all that, if we can all work as physicians as part of a network together in each CSI of the local chapters and then put their programs together and then work nationally, ultimately towards the body to create, and it's also API, it's not only CSI, many physicians treat these are my patients. So we should involve API also aggressively in this treatment of patients with myocardial infarction.
When you talk about this in this case of Kerala, I have to make one more point, that we are not understanding the political DNA of the country. We are talking of only two states, Paschim Bengal and Kerala. These are basically communist bastions, so as to say. The rest of the country is capitalistic. They move towards capitalism. So bringing these guys together in Kerala is far easier.
Not same today.
No, listen. It is easier said than done in Bombay. It is easier said than done in Bombay. What you can do in Kerala, you can never do in Bombay. You will never do it in Pune. You are not going to do it in Bangalore. So the DNA is also a matter. This is a political DNA, capital.
But Madhika, let me just make one point. In Haryana, Dr. Shantanu, this is for your information also. In Haryana, there are 4 cath labs, which is private-public partnership. And I think that's a very progressive way that they're doing it. And we're starting the program there, our STEMI program there in the next month or so. So this is worked in Haryana. So different states are very different. Haryana is an example of cath lab in a public-private partnership. Samir, you would say.
I've been wanting to give you a slightly different perspective, but before that, three or four excellent presentations. I had missed some of the earlier part. A quick remark on Dr. Mardikar's, he mentioned about very eloquently about the ST segment resolution and TIMI 3 flow. Harsh, over the last almost 15 to 18 years, I have completely moved on to myocardial perfusion grade, which I think is, starting from Mike Gibson's work. And I think we rely too much on the epicardial vessels, whereas most of the issue is in the distal microvasculature. And I've become a very huge proponent of large doses of intracoronary vasodilators. That's one thing. The second aspect where you mentioned also very correctly that have we reached the limit, I'll tell you another way to look at it. I think we have reached the limit in the process with the door to balloon times, but we are just beginning to scratch the surface of the real area, which is the symptom to balloon time. Once you're able to address that and particularly have methodologies to identify the patient's accurate diagnosis, probably with the use of artificial intelligence for a self-diagnosis, I think you make a huge difference. Now, regarding the overall feeling from a 40,000 feet looking at India, and I always like to congratulate Thomas and Ajit for their STEMI India initiatives. But as I see it, there are two major problems. I remember the first COVI Lumen meeting in 2008. One of the statistics I showed was in the United States, only 4% of the cath labs were doing a door to balloon time less than 90 minutes. Now it is 97% of the entire country is able to do it. And believe me, it never happened due to magic. It was all sorts of involvements with industry, with the American College of Cardiology, American Heart Association. Just that when I look at India, the change is there, but the speed of change is absolutely snail-like. It needs to be so much faster. I have always been surprised why exactly is there inertia, and you've got all these young Indians dying from something which is so eminently treatable, and we are losing so much time in all the political bickerings and whatever be the case. Once again, I know it is easy to mention it looking at a distance and much harder for you. My last point and observation is also beyond. I have always realized that a success of any STEMI program is directly related to the ambulance care. Beyond that, I think in India, one of the biggest issues you're having is a maldistribution of resources. There are more cardiac cath labs in New Delhi than in the entire state of Florida. And yet again, you've got cath labs in India where even with the PCI availability, patients get streptokinase. So there is a lot more work which I think needs to be done. I think the speed of getting stakeholder involvement, and I lean much more on this on the private. I think maybe the device manufacturers need to have a much bigger say. Yet again, I also, since I have been very closely involved with some of the recommendations and guidelines of CSI, I do believe that they are indeed doing a good job in providing guidelines.
Okay, so I think, is there any other question? Anybody else? Ranga, Sarath?
So can I ask you one question?
Yes,
So,
yes,
so
please go ahead.
what do you think would be the role of imaging in STEMI? Because you are an avid imager. So do you think it will improve the outcome?
Well, we've just submitted a couple of papers. Me and Thomas have been looking at this area. So I think two parts. One is this 40-year-old chap who comes in with STEMI. 20% of the Tamil Nadu STEMI project patients were having less than 40 years of age. And that made us think why these patients do get problems. 33% of those patients were smokers, but 67 were not having any other risk factors. Means, they were not diabetic, they were not hyperlipidemic, which you traditionally say as a young MI in American or the European population. So 33% are clearly smokers. We can attribute a risk. But 67% and no risk factors, and means traditional risk factors. No hypertension, no diabetes, no hyperlipidemia, classical hyperlipidemia, nothing. And so what we did in the Madras Medical Mission over the last, say, 3 years was to systematically image every young myocardial infarction who enter a lab, at least those who are thrombolized pharmacoinvasive approach, some with primary PCI. We couldn't do many because obviously doing a OCT in many of these patients is difficult when the patient is having acute chest pain and doing things like that. And we have 72 patients now with OCT studies in myocardial infarction. And I think the whole pathology is different. It is all plaque erosion, mostly. It has nothing to do with rupture. There is no big lipid plaque there. There is no thin cap fibroathyroma. there is mostly lot of thrombus and a mild plaque with endothelial loss. Many of these patients, when you thrombosuction them or you lyse them intracoronary or sometimes give 2B3 receptor blocker, or they are lysed and shifted to our hospital, they have either clean coronaries or coronaries where the thrombus is cleared with lumen areas which are reasonable. And we have now come to a point of time in these patients, we don't stent them at all. We just leave them on medical therapy. And in fact, just day before yesterday, during the imaging session with Gariman's Akiko Mahihara, and we were discussing this issue, and they were really surprised that we have follow-up OCTs at 6 months, and you can see these whole things just stabilize. And in fact, a very provocative question then comes in, do you need at all, even in minor plaque ruptures, where there is no lumen compromise, to stent these patients? You can treat them medically. So I think that this is an area which requires a lot of new work. I think it's a mix of an endothelial denudation with a high platelet reactivity, and thrombogenicity may be related to smoking, may be related to lipoprotein A, which has got an antifibrinolytic effect. It may be related to, prothrombotic factors in the patient. So you have a plaque rupture, a plaque erosion, and the thrombus forms in very quickly in these patients, and they are an unprotected. The rest of the coronary looks pristine. So there doesn't look like there's atherosclerotic coronary artery. It just seems to be minor erosion, and everything else is thrombus. So we've just submitted this 72 patient data to a major publication in the circulation group. So hopefully we will have some interest in this area soon, Sunita, to answer this.
Yes,
I think we should.
Is quite high percentage of this less than 40. Because our data is only, I think, only 4% of our population is less than 40 years having STEMI, at least in Kerala. So there's a difference.
Kerala is always an outlier. I think we should discount Kerala when we talk of India.
Okay,
because you're much closer to the Western population in everything.
So anyway, I think that this is something which is very interesting. We need to see this a little carefully and see how we treat these patients also. Because if you look at the Erosion 1 study, which was published in the European Heart Journal in China, it showed again the same thing, that if you had thrombus only, you don't need to stent these patients. And in fact, if you stent, you're destining a patient, a young man, with this metal. And in India, it's like a metallic valve. They will stop the antiplatelets at some point of time and get a stent thrombus. So if you don't need to do it, you don't need to do it. If you need to do it, yes, you put a stent. But who needs a stent? Who doesn't need a stent? Even in acute reperfusion, has to be decided in a very uncomplicated way. We cannot say, oh, everybody needs now an OCT. That makes it very complicated. So we need to make that simple and say that this is the way these patients will behave. This is the way these patients will behave. And if this can be treated this way first, and then we look at the angiogram again and see whether you need a stent or not, then it makes sense. Because a plaque rupture with a lot of plaque burden with a minimum thrombus is a complete different animal, which is what most patients in the West present. But what we see is less plaque, erosion or rupture, but more thrombus, which makes sense to me that you use not a stent, but some way of removing the thrombus, whether it's mechanical in late thrombus or drug in acute thrombus, which can be white or red, white with antiplatelet therapy and red with, say, anticoagulants and warfarin. And we have this huge group of patients, 36 patients on warfarin and single antiplatelet with 6 months OCTs, absolutely clean vessels. They have nothing in the coronary after that. So it simply means everything cleared out. But it's a small group. You see, I can't generalize it to the whole STEMI population. So that's the problem.
Okay, sir.
Any other questions? I think we had a good session, and it's late in the night, so here, and so I thank all the speakers. They did an excellent job. I thank Samir and my colleagues, Sunita, Ranga, and Sarat Chandra, and all of us to have discussed these issues. The speakers did a great job. I think insurance is an issue. We need to work. I think CSI needs to take a pivotal role, but I think it may be easier, Santanu, to tell the local CSI chapters to take the lead, and ultimately you control it at the national level after that, because otherwise, trying to hold it from one place peripherally is impossible in such a big country. And I think the API and CSI should fuse together, because at least 60% of STEMI is being treated by physicians and not by cardiologists. So we should understand that also in India, and we should be involving them in the treatment so that quick reperfusion is performed in these patients. So thank you very much, and thank CSI for giving us this occasion to discuss these issues. Bye-bye.
Bye-bye.
Good night. Good night.
Bye-bye.